is a well-known. Assalamu alaikum. Our first lecture will be presented now by Dr. Amani Al-Gufaydi. She is a consultant pediatric hematology oncology, and she will talk about recognizing and management of oncology emergencies. Dr. Amani Al-Gufaydi, she's a senior consultant in pediatric hematology oncology and CCC, and she's a well-known. She used to be the chairman of the Department of Pediatric Hematology and Oncology at King Faisal Specialist Hospital and Research Center. At 8 o'clock sharp, we will start the lecture. So we have 1 minute to go. And Khulud, you can start, please, if the lecture is ready. Dr. Amani will be with us if there is any questions after the lecture. Go ahead.
How is everyone? I hope everyone's fine today. My name is Amani Al-Gufaydi, and I'm a consultant in pediatric hematology oncology. And today I'm going to be talking to you about oncological emergencies. Now, an emergency, most of us, when we think about emergency, we think possibly a car accident, someone fell down from stairs, something that in our mind, that's what alerts not just physicians, but non-physicians about an emergency. Now, the challenge with oncological emergencies, it's not like a car accident. You might not know that it's an actual emergency. Sometimes you only have some subtle signs, but these subtle signs are extremely important to know because once you start to identify it, then you're going to know immediately what you're supposed to be doing or not doing, or try to avoid. So that's the challenge with oncological emergencies, is that you might not see it as an emergency when you first encounter the patient. Of course, obviously, if you have a patient that's coming with bleeding, which can happen to an oncological patient, that's obviously an emergency, but that's not always the case. So I'm going to go over what are the things that as ER teams, when they get these patients. Now, these could be newly diagnosed. The patient may never have been known to have cancer previously, so you don't know if he has an underlying malignancy, or it could be a known patient with cancer who starts to develop any of the complications that I'll be talking about. So who does this happen to? We mentioned it could be a newly diagnosed patient which you don't know has a malignancy, an underlying malignancy. It can happen before the patient is diagnosed, after the patient has started chemotherapy, while the patient's on chemotherapy. It can occur when the patient is coming to us to the clinic. By the way, we've had patients, and I'm sure that you've had, from maybe not from cancer patients, but from other specialties, where you get a call, say, listen, I got a patient here in the clinic, the patient's really sick. So the patient can be coming from the clinic, could be coming from their home, could be coming from school. And how it happens, it really depends on the underlying pathophysiology and what's going on with the patient. So as I've previously mentioned, it can occur at any time during the course of diagnosis, during relapse of the patient, or even at the end stage disease. So the assessment, and I think this holds true for all the patients in the ER, usually your first assessment should be quick, and I'm sure this is something that you guys are all very well familiar with. And you need to really focus what is the main complaint or leading symptom the patient is coming with, and try to get a focused history with baseline vital signs, and do a rapid overall physical examination. That should be your first assessment for any patient, definitely. Now, the oncological emergencies that might happen could occur from the disease itself, from the treatment that we gave to the patient, whether it's for the cancer itself or for other issues, such as, for example, you're coming with a patient with medications that may cause bleeding. So it could be from the treatment that we're giving the child. And it could be, remember always, that a cancer patient can develop any other disease such as any other patient. For example, cancer patients can develop appendicitis. Cancer patients can fall and have a fracture. So there are multiple reasons. So it could be related to the tumor, could be related to the treatment, and could be not related neither to the cancer or the treatment the patient is receiving. Now, in this slide, it kind of, I tried to categorize the main oncological emergencies that can happen to children with cancer. You have the hematological oncological emergencies such as hyperleukocytosis, DIC, hemorrhage, metabolic emergencies such as tumor lysis syndrome, hypercalcemia, SIADH renal impairment. Then you have the mechanical, such as pleural effusion, cardiac tamponade, increased intracranial pressure, severe vena cava syndrome, spinal cord compression, acute bowel obstruction, deception, obstructive uropathy, and multiple infections can happen in any of our patients, such as pneumonia, sepsis, fever, neutropenia, typhlitis, and pancreatitis. Now, I'll start off with the first one, which is the metabolic disorders, which is the most common thing that we do see or that we do fear, and that we take measures, even if the patient, as oncologists, even if the patients, they actually don't have any lab or clinical evidence of tumor lysis, we still have this very much deeply rooted in our minds as oncologists. So what is tumor lysis syndrome, and where and when does it happen? So there are tumor types with high proliferative index rate, patients with large tumor burden, or the type of tumor is very sensitive to cytotoxic therapy. Now, from the high proliferative rate are patients with acute lymphoblastic leukemia, even patients with acute myeloid leukemia, and the high-grade gliomas, especially Burkitt's subtype of lymphoma. These group of patients are at risk of tumor lysis syndrome. It can occur before the patient is actually diagnosed. So the patient has not had the diagnosis of leukemia or lymphoma. They come with this derangement. They present with this derangement, which we'll talk about some of the characteristics of it. So it doesn't necessarily have to start after chemotherapy. It could start, like I said, prior to chemo. Most of the cases, it really does happen after starting chemotherapy. As oncologists, we start the preventive measures before we start the chemo. Now, it happens because there's a massive tumor lysis, and there's the release of large amounts of potassium, phosphate, uric acid, and all of these are damaging to the patient. What happens is that there's disposition of uric acid and or calcium phosphate crystals in the renal tubules that can lead to acute kidney injury. These are some of the laboratory investigations that might indicate, sorry, the arrows are kind of weird, but I think you'll understand. The uric acid, if you do your renal profile, you should include the uric acid, and the uric acid will be increased, potassium will be increased, phosphate will be increased, calcium sometimes is either increased or decreased. Now, when a patient comes in with tumor lysis syndrome, he or she might not have all of these laboratory investigations, but this is something that you have to monitor. So you might just have a slightly high potassium, maybe a highish uric acid. Everything is normal, and the potassium is still within normal limits, but that indicates to you that the patient may have that underlying disorder starting to happen. So, like I said, that's why I'm saying it's not so easy to say, well, this is now an emergency, because you might not have everything that the patient may develop. He or she may come in just with a slightly high potassium, but you keep this in mind, and that way you'll be alert to how many times you should do the investigation. Should you add potassium to the IV fluid? And I'll talk about that in a minute. Now, what happens? What's the problem? What is the issue with tumor lysis syndrome? Unfortunately, it can lead to acute renal injury. the patient may actually have pain, abdominal pain, flank pain. They may have anuria. They may have cloud urine. There may be uric acid nephropathy. Other symptoms that the patient may suffer from is GIT symptoms. They may have nausea. And so when you're taking your history, you want to find out, are you vomiting? Is there any diarrhea? Is there any nausea? And then the worst manifestations is developing dysarrhythmias and even sudden death. And alhamdulillah, in general, this is a much rarer things that we see, because patients are worldwide are more alert to bring their kids in fairly early for medical advice. So alhamdulillah, we don't really see that, but that's something to keep in mind. And this is why it's important, because if you're able to recognize it early and you start your preventive measures to not allow the potassium to go up so high and prevent renal failure, these things can be prevented. Other manifestations that can occur with tumor lysis syndrome are convulsions. So what are the preventive measures? When I see a patient that may be at risk of developing tumor lysis syndrome, I'd restrict the dietary intake of potassium. I restrict phosphate uric acid. I may need to keep the patient NPO. Consult, don't shy away from consultation. I mean, I know everyone, even when I get calls from the ER, oh my God, it's the ER again. But that does happen. Sometimes I don't say that, sometimes I do. But do not shy away from consulting people. Consult nephrology, consult the ICU. Of course, you need to consult your consultant. But again, this is something that you get into the habit of doing, because it's always better to have multiple people involved and get different opinions. I mean, you don't want different opinions, but you want opinions that can help you to decide what's the best line of action for the patient. And you would need to, of course, monitor the potassium, the phosphate, the calcium, uric acid, the urea and creatinine, usually, and also the LDH, the lactic dehydrogenase. You need to order that. And usually we order it every 6 to 8 hours. It's unlikely you would need it at less than 6 hours, but it depends really on the clinical scenario. Now, what are the treatments? Allopurinol, what we usually give is allopurinol, and it blocks the production of uric acid, and we use that as from the very beginning. Sometimes the uric acid extremely high. So we may need, and especially if the patient is very sick. Now, remember, allopurinol is it's an excellent medication, and it's not expensive. So that's what we use most of the time, and it's very effective. But in some situations where the patient has extremely high tumor burden, how do I know if a patient has extremely high tumor burden? Clinically, if I have a child with significant lymphadenopathy and hepatosplenomegaly, then that's most likely a child that probably would benefit from rasburicase. Now, go ahead and start the allopurinol. You could always stop it and switch to rasburicase depending on the situation. Or if I did my CBC and the child has an extremely high white blood cell count, this is a child who is at very high risk of developing tumor lysis syndrome, and this is someone that I may consider giving rasburicase. And what rasburicase does, it oxidizes the uric acid to allantone, which is very, very soluble, and so it prevents the accumulation of uric acid and decreases the kidney injury. Now, besides giving products to reduce the uric acid in the blood, you want to give good fluid hydration. We usually give 3 liters per meter square over 24 hours. Now, you do have to take into consideration if the patient has hypovolemia, or the opposite. If the patient has hypovolemia, you're not going to get too worried about giving a whole bunch of fluids. But if he's fluid overloaded or he has cardiac failure, then you do have to kind of balance it. You might want to give a little bit less, but usually the standard is giving 3 liters per meter square. You do not add sodium bicarb. This is a very old-fashioned thing that people used to do, including myself. Now it's stopped. You would want to ask the nurses to have a strict intake output. You want to do the daily weight. Okay. Okay, we talked about that. Other things that we want to do is restrict potassium. We do not put potassium in the IV fluid. You can, and this is one of the things that happens with tumor lysis is hyperkalemia, and this is one of the reasons why patients may develop cardiac arrhythmia. So you want to restrict any potassium, whether it's from the diet or whether it's from the IV, where they're putting it in the IV fluid. So you want to remove any potassium in the IV fluid. Other treatments for hyperkalemia, we use kyaxylate. It binds potassium in the intestine. There's also other potassium binders. We rarely have to use them, such as sodium polystyrene sulfonate. We hardly use it, but it can be used. Sometimes we need to give the patients Lasix. Unfortunately, some patients, despite restricting potassium, despite giving kyaxylate, despite giving Lasix, they do require dialysis. Most of the time, the type of dialysis we use is CRRT. We sometimes need to use insulin to shift the potassium intracellularly. Sometimes also beta agonists such as albuterol nebulizer can be used. And to stabilize the cardiac membrane, you can also add calcium gluconate. Dialysis, what it does is prevents irreversible renal damage and other life-threatening conditions. And as I mentioned, it could be, now the dialysis, when we do dialysis for tumor lysis syndrome, it doesn't necessarily need to be just potassium. It could be because of a high uncontrolled phosphate, or if the patient has fluid overload, or the patient's uremic, or has symptomatic hypocalcemia or hyperuricemia. Hypercalcemia is another metabolic complication that may be seen. It usually, or it occurs in patients, there may be increased bone resorption, local bone destruction, there's decreased renal excretion. These are the causes, enhanced intestinal absorption. So these are some of the pathophysiological mechanisms that hypercalcemia can occur in. And the diseases that we see hypercalcemia include patients with metastatic disease. Obviously, breast cancer is not in kids, but breast cancer, in adults, lung cancer, multiple myeloma, head and neck tumors, lymphomas, leukemias. Some of the risk factors for hypercalcemia include immobilization, the use of thiazide diuretics, hormones, or even just oral intake. There may be symptoms that are related to hypercalcemia, which includes fatigue, lethargy, confusion, nausea, and constipation and thirst. So these are some of the questions that you're going to be addressing to the patients. So what do we do with a patient with hypercalcemia? We want to give good hydration. We might need to increase the renal excretion by forced normal saline diuresis. We could also give calcitonin to inhibit the bone resorption. Other medications include biophosphate and metharamycin, and of course, treating the underlying malignancy. Now, the syndrome of inappropriate ADH is another metabolic disorder that can be seen. It can occur secondary to various chemotherapeutic agents. It could be direct injury of the brain, such as a child who has had a brain tumor, has had surgery to the brain, has had radiation therapy, and rarely it occurs in patients with lymphoma, but it can. And in adults, we see it in small lung cell cancer, pancreatic cancer, neuroendocrine tumors, and lymphomas. That should be non-small cell lung cancer, lymphomas, and metastatic lesions in the brain. Now, one of the symptoms of SIADH is early symptoms include weakness, fatigability, nausea, vomiting. The patient may be thirsty, have diarrhea, headache, confusion, decreased urinary output, and weight gain. Now, again, you see, the thing is, when you're talking about emergency, they might not have all the symptoms. It could be just he's fatigued, but that should alert you. Late manifestations, mental status changes, convulsions, coma. And the laboratory investigations, obviously, patients have low sodium, low serum osmolarity, and in the urine, it's the opposite, high sodium and high urine osmolarity. How do we treat SIADH? We treat the underlying malignancy, restrict the fluid. In severe cases, we may need to give infusion of 3% hypertonic saline. Now we'll move to the hyperleukocytosis. So what is hyperleukocytosis? It's a patient who has a high white blood cell count above 50,000. Now you might see different definitions. Some people say more than 50,000. Some people say more than 75,000. Some people say more than 100,000. In general, if someone has a white blood cell count of more than 50,000, I would consider this as hyperleukocytosis. The most common cause is acute lymphoblastic leukemia. And what happens pathophysiologically, there's increased blood viscosity secondary to this high white blood cell count, and the leukocytes basically aggregate in the blood system. So what happens is that there's stasis in the small blood vessels in the microcirculation, such as the brain, the lungs, and the renal glomeruli. And what does this lead to if there's stasis? It can lead to ischemia, hemorrhage, and edema of those involved organs. The patients, they may have no symptoms, by the way, but they can present with mental status changes. They can present with stroke. They may have renal or pulmonary insufficiency. So what is the initial management? If I have a child that comes to me to the emergency room and his mental status is not that great, and I do a CBC and I find that, the child has a high white cell count of, like, let's say 65,000, I'm going to start, I want to give him some aggressive hydration, taking everything into context. And this could also help in preventing tumor lysis syndrome and correction of some of the metabolic abnormalities that I've mentioned. Now, these patients with leukemia, when they come in, they may have very high white count, but they may also be anemic and thrombocytopenic. Now, when they're anemic, you don't want to give them, our usual dosage for packed blood cells is 10 mLs per kg. But if you have a kid with high white blood cell count, we cut down and we give 5 mLs per kg, and we even sometimes have to give Lasix afterwards. So you need to take, again, this into consideration. Now, leukapheresis, in the past, it used to be used. It really doesn't have much of a benefit. There's a lot of complications to it. I mean, besides the complications, the benefit has really not been proven across the board. Because even if you do the leukapheresis for a kid, in a few hours, the counts go back up again. So it's really reserved for kids with really high white blood cell count, and more so for kids who are symptomatic. So even if a patient has extremely high counts, but they're asymptomatic, I might not do leukapheresis. Just giving the IV fluid hydration, by the way, has shown to cut down on the total white blood cell count. And of course, starting the treatment is the most important thing. Another feature that we see that may develop in a child who was even undiagnosed or after starting chemotherapy is DIC, disseminated intravascular coagulation. And this is an emergency case, of course. And what happens is that there's activation of the hemostatic system, and there's widespread intravenous deposition of fibrin and consumption of platelets and coagulation. Okay, so this is something that could be seen in the children. Bleeding and thrombosis are the hallmark of DIC. The kid may have petechiae, purpura, hematomas, hemorrhagic bulli. And they, of course, if they're going to have surgery or any trauma or venipunctures, they will bleed excessively. But the most common, if the question comes to what is the most common malignancy associated with DIC, is acute promyelocytic leukemia. It occurs in 80% at the initial presentation of these patients. The laboratory findings: low platelets, less than 100,000. Fibrinogen is low. PT and PTT is prolonged. There's increased fibrinogen D dimers, and request a peripheral smear usually should come out within a couple of hours, and you would see the schistocytes. Treatment: you have to treat the underlying disease. Most of the time, they require platelet transfusion and fresh frozen plasma. So these are some of the basic treatments that you all know. Now we'll go to the mechanical oncological emergencies. Now, when we say mechanical, that means really something that's pressuring something. And of course, that something is important. And so you want to kind of, whatever it is, you want to relieve it. Now, that kind of a pressure can occur from the tumor itself, can occur from bleeding. So the patients can bleed. We know our cancer patients are going to receive chemotherapy, and they might have bleeding, internal bleeding, whether in the brain or in the abdomen, anywhere. So it doesn't necessarily have to happen from the tumor itself. It could happen from the complications, such as bleeding, or there's an abscess, or there's the mechanical emergencies don't just happen from the tumor itself. So these are basically the things that could be seen: superior vena cava syndrome, increased intracranial pressure, spinal cord compression, pleural effusion, airway obstruction, pericardial effusion or cardiac tamponade, and intestinal obstruction. So this is a picture of a child with superior vena cava syndrome, and superior vena cava syndrome occurs due to complications of masses in the chest. And what happens is that the patient develops symptoms and signs of upper body venous congestion. That what it leads to is obstruction of the venous return through the SVC. And you can see the picture of this child showing his neck and his upper part of the chest is swollen. And you can see in the chest x-ray what a huge mediastinal mass this child has. Superior venous syndrome occurs because of external compression by a mass or an intrinsic obstruction secondary to thrombosis, bleeding, or an infectious process. Internal obstruction occurs more as a complication from, for example, and most of the patients that we have central venous catheters. So these catheters can be thrombosed and also cause superior vena cava compression. The diseases that can be caused by superior vena cava syndrome is acute leukemias. In particular, it can occur in any of the leukemias, but more so in T-cell leukemias. It can occur in lymphomas, sarcomas, neuroblastoma, and Hodgkin lymphoma, and even Burkitt's lymphoma. And you saw from the picture, you saw the congestion, the venous dilatation. They could in the face and the neck and the upper part of the chest, and it could be in the arms. If it's other manifestations, especially if in the brain, the kid could have headache and altered mental status. For mediastinal masses that cause superior vena cava syndrome, you have cough, dyspnea, dysphagia, orthopnea. Could be because of pleural effusions. They may have wheezing, hoarse voice. They may also have pericardial effusion, and as mentioned previously, facial edema, and they could have chest pain. The investigations that the initial investigations, basic investigations, just do a plain chest X-ray, and the chest X-ray will show you if the patient has a mass. Now, sometimes it's subtle, so you need to do a CT of the chest. An MRI angiography will depend on your clinical and your imaging findings to determine whether or not you need an MRI to be done. So how do we treat these kids? Immediate supportive care includes oxygen. You want to elevate their head. You want to properly position the patient to minimize obstruction. And you have to maintain a calm and quiet environment. I know this doesn't really sound like it's significant, but trust me, this is very significant. Calm your patient, because once you calm the patient, the problem is when someone cannot breathe, and I'm sure that many of us, including myself, have had, especially if you've had asthma, if you've had any reactive airway, for any other reason. Not being able to breathe is just so scary, and so you need to calm the patient down. It works, and keep them in a quiet environment. Medical treatments include moderate diuresis, and the patient may be required to be admitted to the PIC. Remember, consult people, consult the ICU staff. If it's from a tumor, of course, you want to establish a tissue diagnosis. That's what the oncologist is, usually arrange. And then there's various other treatments such as radiation therapy, steroids, or actually starting chemotherapy. Now, in the emergency room setting, I think the most important thing is, like I said, what I mentioned, keep the patient sitting up, put some oxygen, put them in a quiet environment, think about giving them Lasix, and then again, consult the oncologist. If you think the patient is extremely sick, just go ahead and give steroids. But usually we don't. The reason why we don't like giving steroids as oncologists is that sometimes it masks the diagnosis, and you end up as oncologists doing multiple biopsies until you get a final diagnosis. So we kind of shy away from giving steroids until we get the definitive diagnosis. Now we'll talk about increased intracranial pressure. Now, there are also multiple reasons for increased intracranial pressure. Now, when a patient comes to the emergency room, especially in the beginning, a child, 5-year-old kid who's been playing and, he or she's not really, they're okay. And then the mom noticed there was some imbalance, and then he fell and he hit his head and he came to the ER. So this is, and then the mom's bringing the patient to the emergency room with the consciousness level not that great. Okay, so that might be a clinical scenario. I mean, by the way, most of the kids with brain tumors, their first presentation is in the emergency room. Not all of them. Some of them may just come to a pediatric clinic or pediatric neurology clinic, but sometimes as their first presentation, they come to the emergency room. So you're dealing with a kid with something that indicates it's something in the brain. You're not going to, of course, in your mind think, okay, this is a brain tumor, but you need to go through that process of thinking, okay, what's the most common thing that a child who has sudden, especially if it's sudden, was there a trauma? Did someone push the kid? Was there any kind of abuse? Is the child febrile? Is there an infectious process? But again, you have to keep in the back of your mind that could this be a tumor that's causing the altered conscious level? So I'm not going to talk about the other causes of increased intracranial pressure. I'm going to mainly basically talk about brain tumors. But when you're investigating these kids, you do have to keep that in your mind, because you don't know. You don't know this kid. You don't know how long the symptoms are. And sometimes it's an emergency. You don't even have enough time to take a proper history. So if after our clinical assessment of the kid in the ER, and we did the CT scan trying to figure out is this hemorrhage from the fall, you find out that no, this looks like a tumor. So the types of tumors that occur in children, the main tumors are primary tumors. Rarely kids have metastatic lesions to the brain, but it can happen, especially in kids with neuroblastoma rhabdomyosarcoma. The most primary malignant tumors that occur in kids is medulloblastoma. But in general, any brain tumor can cause increased intracranial pressure. Other causes of increased intracranial pressure, like I said, hemorrhage or an infectious process. The symptoms: headache, nausea, vomiting, blurred vision, diplopia, unsteadiness, and altered mental status. Remember that these do not all have to happen at the same time. The patient just might come in with vomiting. That's it, nothing else. So you won't know. It's not when anyone puts the symptoms of any disease that you're going to be hearing in your medical career, all the symptoms don't happen at the same time. It would have been very easy to figure out the diagnosis. Some of the features of the headache: it gets worse in the morning, of course, with cough, straining, and it's relieved by vomiting. And the kid, of course, may have vomiting, as I mentioned. Some of the signs: you need to do an ophthalmic examination to see if the patient does have papillar edema. Check if the child has any neck rigidity. From the history, check if the child has had any new onset of convulsions. The focal signs on your logical examination will really depend on the tumor location. In the emergency room, the fastest thing to do is a CT scan of the brain, but the golden standard for diagnosing a child with a brain tumor is an MRI of the brain. If you do find that, then you would want to start the child on corticosteroids. Dexamethasone is the drug of choice because it has a good penetration to the CNS system. If the patient is developing had the herniation rapidly, you want to intubate and ventilate the patient, send them to the ICU. Patient may need mannitol and osmotic diuresis. Now, spinal cord compression can be extramedullary by extradural lesions, and unfortunately, spinal cord compression causes devastating sequelae such as paraplegia, incontinence, and quadriplegia. If a child is coming to you, remember the most common. You guys work in the ER. The most common presentation of any patient in the emergency room is pain. One of the most common presentations for kids is abdominal pain. However, it's very rare for a child to come to the emergency room with back pain. If any child comes to you to the emergency room with back pain, take it seriously until proven otherwise, and then you're going to be relieved. But because if you're able to recognize spinal cord injury or compression early on, within the first 24 hours from the onset of the symptoms, you may be able to prevent this kid developing quadriplegia or paraplegia. So that's why it's important, because if we're able to intervene with whether we're talking about with steroids, with surgery, radiation, chemo, it can help to prevent these devastating manifestations. So that's why spinal cord compression in kids should be taken very seriously. So any kid that comes to you with pain, now on the opposite hand, adults always have back pain, especially women, for various reasons. So in a child with back pain, you need to take that seriously and investigate the kid. The most common initial symptom is back pain, red flag in kids, and this occurs in a large proportion. So if someone does have spinal cord compression, it does cause pain, and the pain could be constant. It's worse with coughing and sneezing or straining, and it's worse if the patient's supine. The patient may have weakness. There may be loss of gait and paralysis. There may be sensory loss, loss of bladder and sphincter control. So these are some of the other symptomatology besides the back pain, the symptoms and signs of the back pain that the patient who's presenting with back pain may have. So these are some of the areas. And when you think about the cervical spine, these are some. So what I did here was I put for you the cervical spine, thoracic spine, and lumbosacral spine tumor or lesions. So in the cervical spine, the patient may have headache, may have weakness of the arms and legs, may have some breathing difficulties. If the spinal cord compression is in the thoracic area, there may be pain in the back or chest, and there may be loss of sensation below that area. In the lumbosacral area, there may be back pain that may radiate to the legs or hip. Again, you have to do your full, as much as possible. I know it's not so easy when you're talking about the emergency room, but you want to investigate, you want to examine the motor system, you want to examine the sensation. It's going to help you decide whether really this back pain is neurological or not. Management, steroids, dexamethasone, surgery, radiation therapy, chemotherapy, really depending on the case. But the initial thing as an ER, when an ER team faces a kid with back pain, you really need to take that seriously and act immediately. Actually, in many hospitals, they have a protocol for the kids who come in with back pain, so they can be investigated immediately. Because for kids with back pain, or any, especially for to do an MRI is extremely difficult. So there's some pathways in some hospitals that are set place so that the emergency room team can have access and order the MRI of the spine. CT scan really doesn't help much for spinal cord tumors. Pleural and pericardial effusion, it's caused by movement of fluid into spaces, either the pleural or pericardium. Obviously, the fluid, again, by the way, pleural and pericardial effusion doesn't mean that doesn't necessarily mean it's the cancer itself, but it can be caused by it could be exudative from the cancer. It could be an inflammatory process. It could be an infectious process, or it can be transudative. So the reasons to have pleural and pericardial effusion in cancer patients are various. These are some of the diseases that the patient may be suffering from, and these patients are at a higher risk of developing pleural and pericardial effusion. This is children with Hodgkin and non-Hodgkin lymphoma, acute leukemias, especially if the kid has a high white blood cell count, also germ cell tumors. In adults, lung, breast, GI cancers, lymphoma, leukemia, melanoma. So these are the various tumors that can cause pleural and pericardial effusion in adult patients. The symptoms of pleural and pericardial effusion include dyspnea, chest pain, cough, respiratory distress. The diagnosis is usually made by a chest X-ray, and the management will depend on two major factors: the clinical setting of the patient and how much fluid. I mean, sometimes even if a patient comes in, you don't necessarily have to stick in a needle. It really depends on the clinical situation. However, if it's moderate to severe pericardial pleural pericardial effusion, then the patient may need more invasive procedures to remove the fluid. Cardiac tamponade is a serious consequence of pericardial effusion, and it occurs when the fluid compresses the heart chambers and results in reduction in the venous return and leads to eventually decrease in cardiac output. So treatment of patient with cardiac tamponade, you want to give oxygen, bed rest, leg elevation, and the patient may need pericardiocentesis. Physical examination, it may include Beck's triad, which is hypotension, elevated jugular venous pressure, and a muffled pericardium. Patient may have tachycardia, and in severe cases, the patient may present with pulsus or be found to have pulsus paradoxus. Acute bowel obstruction and dissection. This is another one of the mechanical complications that we see in children with cancer. We see them before the cancer, during at diagnosis, or after treatment. Most of the cases, it can occur secondary to any external compression, constriction, or internal obstruction. The constriction from adhesions or strictures is more commonly seen as a post-surgical complication. So if you had a child that had a child with cancer, and could be a child with in the most common cancer, I mean, the lymphomas can occur in the abdomen, the Burkitt's lymphoma, and sometimes these kids actually present with interception or abdominal mass. And that in itself is an emergency. Now, sometimes after going in surgically and getting a biopsy of that, they may develop adhesions, and that in itself at a later time can cause intestinal obstruction. But it can occur not just in lymphomas, it can occur in acute leukemias as well. What are the symptoms and signs? What are the things that might alert me to the possibility the patient has abdominal obstruction? If the patient first, they may have blood in the stools, abdominal pain, they have persistent vomiting, persistent emesis, they may have a palpable mass. You want to do your basic imaging studies and see if there's multiple fluid levels and maybe dilated bowel loops. So if you have this kid that's coming with abdominal pain, he's nauseous, and you may or may not feel a mass, but the kid, has a significant symptomatology. You do your X-ray and you find these multiple fluid levels, then most likely the child has intestinal obstruction. Management, you guys are much better than me in management of patients with acute bowel obstruction for whatever reasons. They may have electrolyte imbalance. You want to correct their electrolytes. You want to properly hydrate them, put an NG tube, keep them NPO, and consult surgery. Now, the last portion of the oncological emergencies is infections. The most common infection that you guys will see for our children are febrile neutropenia. Now, they might not always be neutropenic, but any patient, put this in mind, any child who has cancer, who's on chemotherapy, even if they're not neutropenic, you still want to treat these children with IV antibiotics. Might not be as emergency as a child with febrile neutropenia, but I just wanted to keep that as a footnote. So even if a child is not neutropenic but has fever and comes to you to the emergency room, the child needs to be properly assessed, blood cultures done, and start IV antibiotics. And then you can decide how aggressive you want to be with antibiotics depending on the patient's situation. But fever, neutropenia, sepsis, pneumonia, typhlitis, pancreatitis. I just put some of the infections. Any infection can happen. I mean, kids with can come with osteomyelitis, can come with septic arthritis, can come with an ear infection, eye infection, and so on. But I just put these as the things that these are things that you need to take more seriously. Okay, so patient may come in with fever. You can ask about the symptoms and signs, do your physical examination. You want to assess the kid, do the CBC differential. Of course, you can do your renal hepatic profile. You need to do a blood culture. Now, the urine, sputum, and pharyngeal cultures will depend on the clinical scenario. Not all kids will need that. chest X-ray. CSF studies is not necessarily done for all kids. It will depend on your clinical judgment. The combination therapy, what we use in King Faisal for the time being is tazocine and gentamicin. If they're neutropenic, non-neutropenic patients receive ceftriaxone. Now remember, these antibiotics, by the way, every couple of years, depending on what's available in your hospital, what in regards to the types of infections and the types of resistance that have happened in the hospital. So maybe now, this year, 2024, we're giving tazocine, gentamicin. Next year, we might need to change if the organisms start to become resistant to it. But in general, that's the basic thing that we do, is a combination of aminoglycoside and an anti-pseudomonal beta-lactam. So this is what we went through. We talked about hematological, oncological emergencies, the metabolic, infectious, infection, and mechanical. And I want to end my talk with just a couple of questions that I hope you will be able to answer. And inshallah, I hope I made this easy for everyone. So the first question: the following is considered an oncological emergency. So think about that question. And then, what are the metabolic derangements of tumor lysis syndrome? What is the most serious complication of tumor lysis syndrome? What are the essential components of treatment of tumor lysis syndrome? So we've talked about it before, but I wanted to poke your minds into thinking of questions. What are the metabolic derangements in SIADH? What is the definition of hyperleukocytosis, and what is the most common malignancy that it's seen in? And what is the underlying pathophysiology? What is the most common malignancy associated with DIC? How to diagnose DIC, and when is the treatment, and what is the treatment of DIC? What are the mechanical causes of oncological emergencies? What are the different types of infections that may be seen in cancer patients? And I think that's the end. So I'd like to thank you so much, and thank you so much for giving this opportunity. And let me know if you need any questions. Thank you.
Thank you very much, Dr. Amani, for this excellent presentation and highlighting about the pediatric hematology and oncology emergency that we used to see a lot in our emergency department. I think because of the time, and your lecture was really more informative and a little bit long, we will go to the next lecture, and it's my pleasure again to present and introduce Dr. Fadi Al-Khattabi. She is.
Yes.
Who are the parties involved in the response team 1919?
So 1919, it's belong to the Ministry of Human Resources and Social Affairs. And the people, they usually, in the phone call, the social worker doing the triaging, depend on the severity and the quick response. And usually the team, they will respond social worker and psychologist. Thank you.
Excellent. طيب, Doctor, I have another question here. You mentioned yesterday about do you screen staff for burnout at your center?
So the burnout, the most important thing is prevention and screening. Teaching leaders and manager, that's one thing, just to recognize the red flags on their staff. Other thing, we're establishing wellness clinic, belong to the family medicine clinic, and another clinic, lifestyle medicine. A part of it's screening for mental health and stress. So yes.
Excellent. طيب, Doctora, do you have any ideas to decrease sleep disturbances associated with the physician changing work hours in the emergency department, please?
Definitely, that's a huge topic in research, and the most important thing usually trying to have a circadian rhythm doing the shift, so following morning, then evening, then night shift. And the most important thing, taking nap, having a scheduling, monitoring and measuring the fatigue, and decreasing the caffeine. And sometimes advises to take melatonin in some of them if that's really affecting them, and seeing sleep specialists in some of people if it's really stressful for them.
What about decreasing the number of shifts? Because we notice, like Ministry of Health now, the maximum number of shifts they have, like 12 shifts per month, while in some other centers they are forcing their staff to have more than 16 to 20 even sometimes. Is there any way we can have like a policy for this? Especially we have noticed there is some victims and some attacks of collapse in the emergency department for those who've been working, a huge number of shifts and working very hard. What do you think, Victoria?
So that's maybe affecting all the general performance plus the sleep. So it's not only the sleep. So especially in this very stressful environment, and let them like reaching the burnout. And the most important thing is just having a time-life balance, and trying dividing things. Now, I cannot say what's number exactly, because Dr. Fifian, you're a senior emergency physician in the kingdom. Some of the centers it's different than the other. So the load, the amount of patients. So the number of the shifts that I think it should be studies from your specialities as to have a standardized related to the maybe tertiary community and primary centers. But for the sleep, as I said, like just the people they're putting the schedule, they have to be very cautious about the rhythm putting people, because the problem with the cardiac the rhythm usually it's between the light and dark, and it's the worst, getting worse with people working in 24-hour shifts. So 8 hours, the percent of medical errors, patient quality care, it's less, but having a circadian rhythm and trying to monitor that. Thank you.
Thank you very much, Dr. Fadia, and it's really a pleasure to have you with us, and we wish we'll see you again in our future conferences. Thank you. Now, it is my pleasure to present and introduce Dr. Ilham Al-Qahtani. She is a pediatric and adult, ophthalmologist, and she is the chairman of the Department of Ophthalmology at King Faisal Specialist Hospital and strabismus consultant. Dr. Ilham will talk about ocular emergencies in children. And if you have any questions, she will be with us. Dr. Ilham, you can start, please.
Thank you, Dr. Saad, for giving me this opportunity to share with you the most important topic you can face every day in emergency room, the ocular emergencies in pediatric. My name is Dr. Ilham Al-Qahtani, Chairman of Ophthalmology in King Faisal Hospital. So today we'll share the most important and the common cases you might face in emergency room with discussion of initial management. So as you know, with increasing medical complexity, most physicians' width of knowledge has decreased as their depth of knowledge has increased. And you have to be aware about the 5-minute rule, which is anything outside of your area of expertise, the vast majority of problems can be solved with a small knowledge base. So the most important to know how to take the vision, and don't be afraid to look at the eye. Know the basic about common and visually threatening eye disease. Any condition that patients potential to have vision loss or permanent structure damage considered as emergency, and you have to call the ophthalmologist. So the common type of symptoms or history you can face in emergency, the patient can come with a history of sudden or gradual vision loss, and a history of a trauma, history of red eye. So what questions you have to ask? The most important, the onset, if it's suddenly noticed or gradual, and the vision loss, take the details of the vision loss, if it's in one eye or both eyes, associated with visual field loss, if it's associated with pain or redness or discharge, and the other associated factors, like if there is history of contact lens wearing, photophobia, medical history like diabetes or hypertension. So the first component you have to examine as an emergency physician, the vision, to take the vision and the slit lamp examination, a quick slit lamp examination to have a general idea about what's going on. So, and you have to be aware about the normal anatomy of the eye, the general one, like the conjunctiva, the normal cornea, and the pupil shape and reactivity, and the lens red reflex. At least you have to know the normal red reflex. This is the shape of the normal fundus. This is how it looks like with the direct ophthalmoscope, the normal optic nerve with the normal vasculature of the retinal blood vessel, and the macular reflex normal. So we'll discuss the most common cases you might face in emergency as a clinical scenarios. So for the first case, like if you have a 10-year-old girl playing with her cousin and poked in the eye, came to the emergency with the pain, redness, and tearing. After the examination with the fluorescent test, you will see this greenish spot in the cornea. And this is very common, you can see in emergency, which is the corneal abrasion. So the most common eye injury can cause corneal abrasion, and the very important test you have to do is a fluorescent test by applying the fluorescent drops. And if you have this stain, that means there is corneal abrasion, so you have to start the patient on antibiotic drops, and you have to rule out leak from the eye to rule out penetration of the cornea. If the patient is a child, always avoid patching. The second case, a 12-year-old boy with a history of trauma while he was confined with his dad drilling, and he came with history of pain and eye tearing. After examination, you find this blackish spot in the conjunctiva and blackish spot in the cornea, which represent corneal and conjunctival foreign body. And this is very common, you can face in the emergency room. So in such situation, you have to apply topical topical anesthesia, then topical antibiotic, and try to remove it with jugular forceps. If you are unable to remove it, call the ophthalmologist immediately to remove it. Then send the patient to home with the topical antibiotic. The third case scenario, 16-year-old boy gets into a fight at school and results in laceration in his forearm from a knife, and he is holding his eye in pain. When you examine his eye, you find this corneal and scleral laceration. So usually sustained during penetrating or blunt trauma, corneal scleral laceration are repaired surgically by ophthalmology. So as emergency physician, you have to keep the patient NBO, call the ophthalmologist as soon as possible, and place the eye shield to protect the eye because it's open, and start a broad spectrum IV antibiotic. Sometimes we need to do imaging if there is a history of foreign body to rule out retained foreign body inside the eye. So the case, case number 4, if you have a 5-year-old was running and fell, and his face hit a metal object and cut his eyelid. What do you want to know and why? So the patient has this picture, lid laceration. You have to know where is the lid laceration exact site, if it's involving the lacrimal system or involving just the lid, and if it's superficial or deep. Why those questions important to know if you can able to manage by primary repair, or if you have to call the ophthalmologist, because if there is lacrimal system involvement, you have to call the ophthalmologist. If it's full thickness laceration, you have to call the ophthalmologist. If it is just superficial involving the lid, only the lid skin, so you can do it as a primary repair. So this is another case of eyelid laceration secondary to the dog bite. In such situation, it is full thickness. You have to call the ophthalmologist for primary repair and cover the patient with antibiotic and consider rabies prophylaxis as its result from the dog bite. The fifth case scenario, 16-year-old boy playing baseball. Was at third base and got hit in the eye with the baseball after the hitter hit the ball. And before entering the room, you see the CT scan and you find this. So as you see from the CT scan picture, there is a globe rupture with orbital bone fracture. So this is the picture of this how the patient look with lid laceration and globe fracture. In this situation, you have to call the ophthalmologist as soon as possible. So globe fracture should be treated by the ophthalmologist only. The size of the peak, the rupture globe, if you see the pupil is peaked. That means there is a leak inside the eye and you have to call the ophthalmologist as soon as possible. If you see a sidal test like this leak, that means there is a rupture globe and you have to call the ophthalmologist. So the goal from the treatment of the rupture globe to avoid any increase in intraocular pressure. So you have to apply eye shield only, never patch the eye, and give the patient any pain relief, NPO, then broad spectrum antibiotic, and ophthalmologist consult immediately. In this case, you can, when you ask the patient to look up, you can see right eye, the eye is frozen and can't move up. What are you suspicious of? Orbital floor fracture. When you do the CT scan, you can see the orbital floor fracture. The most important thing in this case is to rule out entrapment of the extraocular muscle. So the mechanism of injury, usually blunt force. The weakest area of the orbit bone is the orbit floor, maxillary roof, which is called blowout fracture. So the other signs included in such situation: eyelid swelling and ecchymosis, enophthalmos, ptosis, double vision, anesthesia of the cheek, and because involvement of infraorbital nerve, inability to move the eye upward. So in emergency department, you have just to ask for the orbital CT scan. Sometimes the plain film may be helpful. So give the patient tetanus prophylaxis according to the type of the injury. Surgery is not always indicated. Arranging ophthalmology follow-up for possible surgical repair. The surgery is most commonly performed after 7 to 14 days when the edema is subsided. Prophylaxis antibiotic may be an option. Until the patient to avoid blowing their nose. Case number 7, a 3-year-old girl comes in the emergency with eye pain after getting trauma in the eye with a toy truck. When you examine the patient, you find this, a hyphema, blood inside the eye. So the blood in the anterior chamber from the iris bleeding usually result of a blunt trauma, significant risk of secondary bleeding in 3 or 5 days with outcome poor. So the treatment, first of all, education of the patient by having the patient sit upright or bed rest with 30-degree, shield or patch the eye, diuretic to decrease intraocular pressure, refrain from taking any aspirin, and refer the patient to the ophthalmologist. Please don't confuse hyphema with subconjunctival hemorrhage. Subconjunctival hemorrhage always, it's most frequent you can see in emergency, and it looks like this. This is another picture of subconjunctival hemorrhage, which is completely different than hyphema. Subconjunctival hemorrhage, it is self-limiting, no need for treatment. It's very important to know the underlying cause. Is it secondary to trauma or secondary to increase intra-abdominal pressure, like if there is a history of constipation or coughing or vomiting, which cause this subconjunctival hemorrhage, or uncontrolled blood pressure. So it's very important to treat the underlying cause, and it is self-limiting, it will resolve by itself. Case number 8, a 5-year-old boy present with red painful eyelid started at morning when he wakes up. On examination, you find this swelling upper and lower lid. So this is most common also you can see in emergency, which is periorbital cellulitis. An infection of cells around the eyes, a major ophthalmological emergency if it is causing limitation of eye movement. And the most common bacterial, secondary to the bacterial infection. So the associated symptoms, usually pain, conjunctival erythema, and sometimes fever. It's very important to take the visual acuity of the patient, to check the pupil and the extraocular movement. We need CT scan if we have doubt of orbital cellulitis, culture, gram stain, and blood culture. So the treatment, if it's periorbital cellulitis and the patient age below 2 years, need admission and IV antibiotic. If more than 2 years, we can treat him with the systemic antibiotic and daily follow-up. So the orbital cellulitis, it is causing always proptosis and decreased motility and decreased vision, and can cause afferent pupillary defect. It needs emergency CT scan to rule out abscess. So red eye, always you can see various causes of red eye in emergency, secondary to dry eye or blepharitis, contact lens wearing, and episcleritis, acute angle closure glaucoma, and endophthalmitis. This is various types of conjunctivitis, secondary to bacterial, allergy, or viral. So the true emergency is chemical burn. So if you have history of chemical burn, it is very important to treat the patient as soon as possible with irrigation for 30 minutes and remove any particular chemicals. Deprived necrotic tissue, may need to treat increased intraocular pressure and call the ophthalmologist as soon as possible. Extent of the injury related to the surface area of the contact and duration, depth of penetration, and degree of limbal stem cell damage. So another emergency cases you might face proptosis. So if you have history of proptosis, sudden proptosis you have to rule out retrobulbar hemorrhage. And this mechanism of injury, usually blunt or penetrating injury, the patient might lead to loss of vision because of central retinal vessel occlusion. And this needs emergency treatment of lateral canthotomy by expert person to reduce the pressure inside the eye. So various cases you might face an emergency like wandering eye. The patient came with inward deviation or head tilt or unable to close the eye. And this is secondary to cranial nerve paresis. The most common is fourth cranial nerve paresis or 7 cranial nerve secondary to Bell's palsy. And so it should be treated accordingly to treat the underlying cause and refer the patient to a pediatric ophthalmologist according to the related cause. So in summary, the eye, very important. And when you have a doubt about anything, you have to consult the ophthalmologist as soon as possible. And the ocular injury is the most common leading cause of vision loss or blindness worldwide. So thank you for listening to my lecture. And this is the references of my lecture. Have a good day. Thank you.
Thank you very much, Dr. Ilham. If you are with us, please open your microphone, please. We have only one question. There is some of the audience were asking, what is the role of eye patch on children with eye injuries? Because some ophthalmologists, they recommend to put eye patch. Some of them, they said it's not necessary. So what is your role, please?
Usually I try to avoid eye patch in children because risk of amblyopia, especially younger children less than 3 years. So if you just treat the patient with frequent lubrication and to reduce the pain, because usually they try to patch the eye to avoid the pain. So frequent lubrication can help the patient with pain and save the vision of the child from amblyopia. Because patching the eye one day, there is a risk of amblyopia.
Thank you very much, Dr. Ilham, and we wish to see you again in our future conferences and courses. Thank you.
Thank you so much.
Our next speaker, it's really my pleasure to present Professor Bassam bin Abbas. He is head section and consultant pediatric endocrinology and diabetes, professor of pediatrics and endocrinology at Al Faisal University. He is staff in King Faisal Specialist Hospital and Research Center. Dr. Bassam will present pediatric endocrine emergency. You can start, Prof.
Bismillah ar-Rahman ar-Rahim. Hi, everyone. First, I would like to thank the organizing committee, the scientific committee, for inviting me to give this talk and to provide this session on the pediatric endocrine emergencies. Pediatric endocrine emergencies are serious conditions that require immediate medical attention. Delayed diagnosis and delayed treatment may lead to serious complications and consequences. This is a brief of some of the common pediatric endocrine problems. I'm sorry. Okay, sorry. These are the some of the common pediatric endocrine emergencies. In brief, diabetic ketoacidosis, hypoglycemia, adrenal insufficiency, hypocalcemia, DI, which is diabetes insipidus, hyperthyroidism, and ambiguous genitalia. I will try in the next 25 minutes or so to go over it as quick as possible. I will start by diabetic ketoacidosis, which is a metabolic complications of diabetes. Usually, it's happening among children with type 1 diabetes and rarely among patients with type 2 diabetes. So timely diagnosis, comprehensive clinical and biochemical evaluation evaluations and effective management are the key to the successful resolution for this medical emergency. This is the triad, the biochemical triad of diabetic ketoacidosis and definition. It consists of hyperglycemia, ketonemia, and metabolic acidosis, high ionic gap metabolic acidosis. This is some figures and to define hyperglycemia. So we're usually referring to a blood glucose above 200 milligram per deciliter and acidosis with a pH less than 7.3 or bicarb less than 15, in addition to ketonemia. Based on the severity of diabetic ketoacidosis and based on the level of bicarbonate and pH, we can subclassify diabetic ketoacidosis into mild, moderate, and severe. So if the pH less than 7.3 and the bicarb less than 15, this is called mild DKA. If the pH is lower, it's less than 7.2 and lower, and the bicarbonate level less than 10, we are usually referring to moderate diabetic ketoacidosis. And the severe ones, if the pH is very low, less than 7.1, and bicarbonate level less than 15. This is in brief the pathophysiology of diabetic ketoacidosis. So in the presence of deficient insulin secretions, and also in the presence of other additional factors like stress, infections, or insufficient exogenous insulin, this might lead to diabetic ketoacidosis. And in this case, the counter-regulatory hormones will be high, which are the glucagon, the catecholamines, cortisol, and the growth hormone. And this will lead to lipolysis and elevation in free fatty acid and ketogenesis. And also this will lead to increased proteolysis and decrease protein synthesis, leading to hyperglycemia. And also in the case of deficiency of insulin, this will lead to breakdown of glycogen, leading to hyperglycemia. And eventually the patient will have dehydration and hyperosmolarity. Okay, so in case of diabetic ketoacidosis, we have to monitor the vital signs hourly or more frequently. We have to monitor the neurological signs hourly or more frequently. And also we have to monitor the fluid input and output, again, hourly or more frequently. And we have to watch for the warning signs of cerebral edema. The biochemical monitoring, usually are doing serum glucose like hourly, electrolytes, again, hourly. We have to do maybe every 4 hours, calcium, magnesium, phosphorus level. In addition to that, we have to monitor for acidosis by doing blood gases every 2 to 4 hours, and also blood beta hydroxybutyrates every 2 to 4 hours. Okay, so the aim of therapy of children with diabetic ketoacidosis to correct dehydrations, to correct acidosis, to reverse ketosis, and also to try to normalize blood glucose as early as possible. And at the same time, we have to avoid complications of therapy. So these are the list of the indications of ICU admission. So if the child has a severe DKA defined as a pH less than 7.1 or moderate DKA defined as pH less than 7.15, in addition to depressed level of consciousness or being young with less than 5 years of age, or having high PON or hypotension. These are additional factors leading to think about admitting this child to ICU. So the management usually is fluid management and insulin therapy. So documentation of all fluids, including the fluid given during the ER, is very important. We have to assess the degree of dehydrations. If the child is in shock, usually we are giving around 10 cc of normal saline per kg. And if the child is not in shock, usually we are giving around 10 ml of normal saline per kg over 1 hour. Okay, so the fluid management will include the maintenance plus the deficit, and we have to assess the deficit level. Moderate, mild, dehydrations is around 3%, moderate is around 6%, and severe is around 9%. So by multiplying the percentage of dehydrations by the body weight, this will give us the amount of fluid deficits, and we have to add that to the maintenance and to be replaced over 24 or 48 hours. Okay, if the blood glucose dropped to around 13 or 16, usually we are changing the IV fluid from normal saline to D10, and if there is further drop of glucose around 10 or below 10, usually we are changing the fluid from D10, so from D5 to D10%. The potassium, generally speaking, children with diabetic ketoacidosis, they are deficient in potassium. So if the serum potassium is less than 3.5, usually we are adding 40 milliequivalent of potassium chloride per liter. And if the serum potassium between 3.5 and 5.5, we are adding 30 milliequivalent of potassium chloride per liter to the IV fluid. The insulin therapy, which is the second element, which is very important in managing patients with DKA, in addition to the fluid management, usually we are giving around 0.1 unit of regular insulin per kilogram per hour till the acidosis/ketosis resolved. Okay, so during management or managing children with diabetic ketoacidosis, we have to watch, as I told you at the beginning, for cerebral edema. So if there is any warning signs of cerebral edema, we have to reduce the rate of the IV fluid. And here a list of some of the medications which might be used in this situations, like mannitol and hypertonic saline. On the right side of the slide, you can see some of the symptoms and signs of cerebral edema. And some of the diagnostic criteria, like abnormal motor function and verbal response, decorticate or decelerate posturing, cranial nerve palsy, in addition to other mild and moderate signs and symptoms of cerebral edema. Okay, cerebral edema is not the only complications of therapy of diabetic ketoacidosis patients. There are other therapy complications, including hypokalemia, including acidosis, hyperchloremic acidosis, hypoglycemia, and inadequate rehydrations. And on the right side of the slide, you can see a complete list of therapy complications, including hypocalcemia, hypomagnesemia, hypophosphatemia, thrombosis, venous thrombosis, pulmonary embolism, and a long list of complications. So we have to watch for that as well. Because of the time limitation, I have to move to the second pediatric endocrine emergency, which is the hypoglycemia. And these are the summary of the symptoms and signs of hypoglycemia in neonates. And this is the way we're classifying the signs of hypoglycemia among neonates into neurogenic signs and neuroglycopenic signs. Neurogenic signs because of the elevation in catecholamines, like uterine tachycardia, pallor, and hypothermia, and the neuroglycopenic symptoms or signs, including lethargy, irritability, cyanosis, tachypnea, and apneic episodes, including convulsions and twitching. Okay, this is the list of the causes of hypoglycemia in neonates, which include large of gestation age, IUGR, infant of diabetic mother, birth asphyxia, being premature or post-mature, and some of the syndromes like Pickles-Whitney syndrome, Turner syndrome, and Kabuki syndrome. This is a brief approach to neonates with hypoglycemia. We are usually categorizing hypoglycemia into ketotic and non-ketotic hypoglycemia. The ketotic hypoglycemia, this will include some of the enzymatic deficiencies, like the glycogen storage disease type 0, 3, 6, and 9, or growth hormone deficiency or cortisol deficiency, and also including glucogenesis defects, and also the other category, which is non-ketotic asymptomatic hypoglycemia, which include fatty acid oxidation defect and hyperinsulinemia. So the goal of treating patients and children and neonates of hypoglycemia to normalize the glucose as quick as possible, to preserve the CNS function by giving IV glucose or oral glucose if the neonate or the child is tolerating that. And this is the just rough estimate about the amount of glucose required. Usually we are using dextrose 10%, between 2 to 5 ml per kg as a bolus, followed by 5 ml of D10 per kg per hour. This is the third pediatric endocrine emergency I would like to talk about, which is the adrenal insufficiency. And the problem could be in the adrenal, or it could be in the pituitary gland and hypothalamus. These are the primary and secondary causes of cortisol deficiency related to adrenal gland. So one of the causes is the congenital adrenal hyperplasia, which is a common cause of cortisol deficiency among our patients, autoimmune polyglandular syndromes, and other syndromes like IMAGE syndrome, ACTH resistance, All-Grove syndrome. There are secondary causes, secondary adrenal causes of cortisol deficiency, which include infections or infiltrations and drugs. The problem could be not in the adrenal gland, it could be in the hypothalamus or pituitary gland, like, for example, hypothalamic tumors, radiation surgeries, or some of the defects in pituitary gland, which lead to ACTH deficiency and subsequently cortisol deficiency. These are the features of adrenal insufficiency, which include anorexia, confusion, dehydration, fatigability, abdominal pain, hyperkalemia, hypernatremia, and hypoglycemia, including hypotension. So children with adrenal insufficiency should always carry with them steroid emergency card, how to give steroid in case they found unconscious, or there's alert also, there's what's called medical alert identifications, or injection kit including hydrocortisone. So this is the way we are treating cortisol deficiency. Usually children are requiring between 50 to 100 milligram of hydrocortisone per square IV or IM in case of cortisol deficiency or in case of surgery, for example. And this should be followed by, again, between 50 to 500 milligram of hydrocortisone per square divided every 4 to 6 hours. But for rough estimation of the amount of hydrocortisones, usually children below the age of 3 years, we are giving them around 25 milligram of hydrocortisone. Children between 3 and 12, usually are giving 50. Children above the age of 12, usually are giving them as 100 milligram of hydrocortisone as a bolus therapy. I will move to the third pediatric endocrine problem I would like to talk about, which is the hypocalcemia. And these are summary of the symptoms and signs of hypocalcemia, which include irritability, tetany, carbopetal spasm, laryngospasm, cramps, spasm, Jovostic and Trousseau signs. These are the signs and symptoms of hypocalcemia. What are the causes of hypocalcemia? There are maternal causes and neonatal causes. The maternal causes will include diabetes mellitus, toxemia of pregnancy, vitamin D deficiency in the mother, or if the mother is taking magnesium, for example, or anticonvulsant treatment. All these can lead to hypocalcemia in neonates. And there are other neonatal causes of hypocalcemia, like low birth weight, for example, asphyxia, jaundice, chronic renal failure, and also anticonvulsant treatment. And by the way, the hypoparathyroidism, one of the causes of hypocalcemia, which can be divided or classified, the causes into congenital causes and acquired causes. The congenital causes, some of the syndromes which are inherited as autosomal recessive dominant or X-linked, like DiGeorge syndrome, Sanchez-Sakati syndrome, Barakat syndrome, and there are acquired causes like the autoimmune polyglandular syndromes, or post-surgery or irradiations, or post-inflammations, infection, or infiltration. There are genetic causes of vitamin D deficiency, which is common among our patients, like rickets, genetic rickets caused by 25 hydroxylation defect, 1-alpha hydroxylation defect, or like vitamin D resistant rickets, and also X-linked hypophosphatemic rickets. So now we'll talk about the management of hypocalcemia. So in case of severe hypocalcemia, usually we are giving 10% calcium gluconate, and this is the dosages in milligram, in milliequivalent, in ml. Usually we are using the ml. For example, if you are using the 10% calcium gluconate, roughly we are giving between 2 to 5 ml of calcium gluconate per kilogram per day. And after giving the bolus of calcium gluconate, usually we are giving a continuous infusion of calcium to maintain the level of calcium post boluses. Okay. But here, very important point here, during the emergency, we have to avoid rapid administration of calcium. And if we want to give IV calcium, this should be under ECG monitoring, because you know that rapid administration of calcium might lead to vasodilatation and hypotension and also cardiac arrhythmias. I will move on because of the time limitation to the fifth pediatric endocrine problem I'd like to talk about it today, which is the diabetes insipidus. And this is a brief classification of hypernatremia, which is the common biochemical features in diabetes insipidus. So there are two common categories of hypernatremia associated with low volume or normal volume. So low volume hypernatremia usually caused by excessive loss of free water, renal causes like diabetes insipidus, GI causes like in diarrhea, for example, dermatological causes like in burns, for example, and there are other causes with inadequate free water intake. For example, in neonates who don't have a free access or an easy access to water, or patients with neurological problems, again, they don't have an easy access to water, they will have definitely hypernatremia associated with inadequate free water intake. And sometimes hypernatremia caused by excessive sodium or intake, like formula, which are concentrated, and other causes. Let's go back to the DI and the causes of diabetes insipidus, which can be classified into central and nephrogenic. And the central can be classified into congenital, caused by genetic defects, or acquired, like tumor, for example, or infections, for example, or other granulomatous problems like histiocytosis, for example, trauma. And nephrogenic DI, again, we have the congenital causes and the acquired causes. The congenital one is the most common cause of nephrogenic diabetes insipidus, and also there are acquired causes, mainly renal problems. So if the DI should be suspected if the child is polyuric, having urine output more than 5 cc per kilogram per hour. In addition to that, a serum osmolality above 300 milliosm per kg. So in a case of DI, there are different formulation of DDVB can be given. And this is a table summarizing for you the different preparations we are using in our hospital treating patients with diabetes insipidus, like the IV preparations, which is the arginine vasopressin, and we have the sub-Q preparations, and we have the sublingual and the nasal solutions as well. Usually in neonates, we are using the sub-Q vasopressin or DDVB, and for older children, we are using the nasal spray or the sublingual DDVB. Okay, moving to the sixth cause, or the sixth pediatric endocrine emergency, which is the hyperthyroidism, and particularly hyperthyroid storm. And these are some of the symptoms and signs of hyperthyroid storm, like difficulty in gaining weight, having irregular heartbeats, having frequent bowel movements like diarrhea, having like moist, warm skin, or nervousness, irritability, poor school performance, and bulging eyes. So the main drugs we are using for hyperthyroidism and hyperthyroid storm, like for example the BTU, which is the propylthiouracil, and methimazole, and these two medications are inhibiting an enzyme called thyroid peroxidase. And at the same time, also we might use what's called an organic iodine, like the saturated solution of potassium iodide called SSKI, or Lugol solutions. And this medication particularly preventing the release of preformed thyroid hormones. Also during the storm, I mean hyperthyroid storm, to block the effect of thyroid hormones, we're using beta blockers like propranolol, for example. And steroid also can be used in thyroid storm to inhibit the peripheral conversion of T4 to T3. I will end my talk by talking about the ambiguous genitalia, which is one of the endocrine emergencies as well. It's a social emergency and medical emergency. So if you have a neonate with genital ambiguity, we have to find out as quick as possible the gender of this patient, whether it's a boy or girl, by doing three things: by palpating for the gonads, doing ultrasound to look for the gonads and uterus, and doing an urgent chromosomal analysis. So if there are gonads by palpation or by ultrasound, and no uterus by ultrasound, and if the chromosomal analysis is showing XY, so most likely we are dealing with undervirilized male with ambiguous genitalia caused by less androgens. And the opposite is true. I mean, if there is no gonads by palpation or by ultrasound, and there's a uterus by ultrasound, and the chromosomal analysis is showing 46XX, so most likely we are dealing with an overvirilized female with ambiguous genitalia caused by high level of androgens. So this is the social emergency, and we can overcome that, as I told you, by doing ultrasound and palpation for gonads, and doing karyotyping. But sometimes the genital ambiguity are associated with a medical emergency, which is electrolyte imbalance, which is salt losing. So the undervirilized males or females can be subclassified into salt losing and non-salt losing causes of genital ambiguity. And this is the complete list of causes of male undervirilization and female overvirilization. And because of the time limitation, I will not go through these details. I will end up, finally, I would like to talk about the micropenis, which is, again, is a social and medical emergency. You cannot imagine that, but it's really a social emergency and medical emergency. But just briefly about what's the difference between micropenis and microphallus. Actually, micropenis is the structurally normal penis with normal opening. But microphallus, here we are dealing with micropenis plus hypospatus. The importance behind dividing or talking or classifying micropenis into micropenis and microphallus, because the causes are different. For example, the causes of micropenis is gonadotropin deficiency and a growth hormone deficiency. The causes of microphallus is androgen deficiency or insufficiency. So the causes, as I told you, this will include gonadotropin deficiency, growth hormone deficiency, which could be a part of multiple pituitary hormone deficiencies, and particularly ACTH deficiency. And here is the emergency: if the child is having micropenis, it might be associated with ACTH deficiency, I mean cortisol deficiency, which might lead to hypoglycemia. That's why micropenis or microphallus are also medical emergency, because of the possibility of hypoglycemia. So how can we define micropenis? Actually, we have our normal standards for stretch penile lengths for neonates and also for children, because really there are ethnic and racial differences. So the definition of micropenis, stretch penile length less than 2.5 standard deviation below the mean. For Saudis, the normal range between 2 to 5 centimeter, and the mean is 3.5 centimeters. So anything less than 2.5 centimeter at birth is considered hypoglycemia, and further evaluation should be done. I think I will stop my talk here, and thank you again for listening. And again, I'm very sorry that to go over the different etiologies or different pediatric endocrine emergencies because of the time limitation. Thank you very much.
Thank you very much, Professor Bassam, for this very interesting presentation. And I hope you are still with us. So, because we have few questions for you, if you can open your microphone, please. I have a question here for Dr. Bassam. According to Saudi guidelines, any patient with DKA better to manage the patient in PICU. What do you think? Because we are still managing patients with DKA emergency department, and we used to send them to the floor. What do you think, Dr. Bassam?
Okay, thank you. First, thank you very much, Dr. Mohammed, for organizing this meeting and for moderating these sessions over the last 3 days. Okay, this is a very good question about diabetic ketoacidosis. Actually, we can classify, and we are classifying a diabetic ketoacidosis into mild, moderate, and severe. So the mild ones actually can be treated in the ER, can be treated in the floor. Not every patient require ICU admission. In the matter of fact, that Dr. Rima Khalifa, who is an endocrinologist, pediatric diabetologist from King Saud University, published her recent paper about managing mild DKA, managing mild DKA in the emergency room. And actually, we are able to manage mild diabetic ketoacidosis and preventing the shift from mild DKA to moderate DKA at home by frequent water intake and asking the children to take frequent small dosages of short-acting insulin. So to answer your questions, not every patient with DKA should be admitted to the ICU. Some of them can be admitted to the regular floor, and even some of them can be treated at home if they are just mild diabetic ketoacidosis. The situation in our hospital is a little bit different because some of the regulations of some of the hospital, they don't allow continuous insulin infusion and hourly blood glucose monitoring or electrolytes monitoring in the floor. But generally speaking, it depends on the severity of diabetic ketoacidosis.
Thank you, Dr. Bassam. I have a question, please, for you. And this is, I think, we have to emphasize on this. Some patients, they are coming to the emergency with a picture of diabetic ketoacidosis, and they are dehydrated. And there was, I think, a study mentioned that in DKA, you don't have to give 20 ml per kg of normal saline. You should start with 10 cc per kg. However, the patient looks dehydrated. What is your advice, please, on this? Because I think most of the staff, they are following this study, and the patient is still dehydrated, and they are only given 10 per kg.
Right. Yeah. Well, and this is by the way, this the fluid management is a controversial issue still. For it has been like this for years. But generally speaking, any patient with diabetic ketoacidosis, we consider him as 10% dehydrated. But maybe I did a mistake during my presentation. I mean, if the patient is in shock, maybe he deserves getting 20 cc per kg as a bolus. But generally speaking, we are treating children with diabetic ketoacidosis with 10% as a 10% dehydrated child, and we are managing him accordingly.
10% dehydration, you mean 10 cc per kg as a bolus?
Sometimes we are giving that, yes. I mean, like, generally speaking, we usually we don't prefer giving boluses in general fluids and insulin, but 10% dehydrations over a few hours we can give it, yes.
Mhm. Okay, thank you very much. As an emergency physician, honestly, most of the patients presented to the emergency with the DKA, they look really dehydrated. That's why sometimes we are forced to give 20 per kg. However, they are not hypotensive, but they are very tachycardic. So they are in compensated shock, we call it. Okay? طيب, I think this is all the question for you, Dr. Bassam. Thank you very much for your presentation, and wish to see you again in our next conferences and courses.
Thank you. Thank you very much. Thanks. Appreciate it. Thank you.
Now we will go back to our questions and answer. I think now we can have a break, and at the same time, during the break, who wish to go, we will start again at 10:15 after 10 minutes, but I will go over the question and answers because we received so many questions, and I will try to answer them during this time of break. Some of them, they were answered yesterday, but I think they keep repeating the questions. Okay. Here, there is a question, I think, for Dr. Amani Al-Gufaydi. Somebody was asking, what is the stratification of a child coming to emergency department with acute presentation of possible oncology emergency? He is already a known case of some malignancy, question mark. Her answer was not necessary, undiagnosed, or just started therapy. So he is not, as she mentioned, it is not necessary to stratify the patient in the emergency department. Another question for Dr. Amani also, Al-Gufaydi, how much is the maintenance fluid in cases of tumor lysis syndrome? Her answer was IV fluid 3 liters per meter square over 24 hours. Another question here from yesterday, actually, and they keep repeating, what is the recommendation for epinephrine frequency in anaphylactic in case of persistence of symptoms, if the patient is still symptomatic? Epinephrine frequency, the answer is every 5 to 15 minutes for persistent anaphylaxis. And you would not repeat if the persistent non-anaphylaxis, for example, if it is local, only urticaria, there is no cardiopulmonary symptoms, only you can use antihistamine. So there is no need for epinephrine in case of isolated urticaria. Like, another question, do you recommend first or second generation antihistamine for urticaria? Again, do you recommend first or second generation antihistamine for urticaria? The answer, we prefer second generation antihistamine as they have a longer half-life and less sedative. However, first generation is sufficient. Example of for those who've been asking what kind of first generation, like Benadryl, which is diphenhydramine, versus cetirizine, loratadine, which is the second generation. Regarding status epilepticus, if I gave 1 dose of benzodiazepine and no improvement, should I go to the second line, or I can repeat the dose of benzodiazepine? For status epilepticus, the goal of benzodiazepine is to stop seizure within 20 minutes. Usually this means we have time to give the second dose. And sometimes paramedics, they give 1 dose during transfer to the emergency, and we can give the second dose. But I think there is no problem. You can give the second or even third dose. After that, we move to our 3 second line agent, like phosphonatoin, which is IM 20 per kg, valproic acid 40 per kg, or Kebra, which is 60 milligram per kg. And there is a link, our technician, they already put it in the answer question and answer box. The link for the emergency management of status epilepticus as per American Academy of Pediatric recommendation. Another question here. What is it? Sometimes delay. Sometimes a delay to get blood culture in sepsis cases can happen, and sometimes it can take more than 1 hour to do so. Until then, the antibiotics should be started anyway. Is it right or wrong? The answer is ideally blood culture should be obtained before starting antibiotics. Failure to do so or to identify the source of infection can present treatment challenges. Significant delay in obtaining blood culture should be potential focus for quality improvement activities. So this is a message to our nurses and our staff that we should encourage to do it in a timely manner. Having said that, if a child is critically ill, then the physician must decide the most immediate course of action and not to delay antibiotic treatment for cultures. Okay? In septic shock, the goal of antibiotics to give it less than 1 hour, and in severe sepsis, it should be given in less than 2 hours. Another question. What age is lactate can be a major marker best choice of treatment of sepsis associated with severe pneumonia with low WBC count and low platelets? According to the answer was lactate can be used even in very young age group like neonatal period for early diagnosis of sepsis. Other questions? What is the minimal age that can be prescribed antihistamine, and what is the safest agent? According to our faculty, it is the minimal age is 6 months. Cetirizine, which is we used to call this Zyrtec, and cetirizine is the simplest and probably the safest, but still loratadine is probably used. They are both least sedative. Also, in addition to these antihistamine, H1 blocker in more severe allergic reaction, I would add H2 blocker like famotidine. I think this question, we answered it. What is the interval between epinephrine? We said 5 minutes. Every 5 minutes you can give it. Do you screen? This is, I think, Dr. Khattabi, she already answered all these questions. There is a question also, do you have like specialized clinic or burnout, and how to reduce the sleep problem by decreasing the shift, by monitoring and measuring the fatigue, by providing education about fatigue? Okay. There is a question for Dr. Ben Amr, our dermatologist, pediatric dermatologist. We have a question about how to treat non-bullous impetigo in pediatrics.
Yeah.
And
الله يبارك يا رب. طيبة.
Saleh, can you turn your microphone off, please? If limited, if the rash is limited to a small area, so Mipricine ointment BID for 5 days will be enough. If it is widespread impetigo, that systemic antibiotics should be started as an IV and usually cephalosporin. I hope I answer most of the question, and I will go back and look into the question and answer box. I think there is a few questions, but because of the time frame, we will do it after the next group of lecture. It is my pleasure now to present our next speaker, Dr. Abdullah Tamimi, who is a pediatric emergency consultant and toxicologist. He is a senior consultant at King Fahd Medical. I'm sorry. The next speaker is Dr. Wadi. I'm sorry. Dr. Abdullah Tamimi will be after Dr. Wadi. Is Dr. Wadi around? You have his lecture now, Khulud? Okay. So our next speaker is Dr. Abdullah Al-Wadi. He's a pediatric cardiology intensive care physician at Prince Sultan Medical Military City, and he's the director of PICU department, and and he will talk about cardiac emergencies in children. Dr. Abdullah, you can start, please.
Hello, everybody. In the coming 25 minutes or so, we're going to discuss the cardiac emergency in pediatric patient coming to the ER. We'll start with the normal anatomy of the heart. As you all know, the heart is a fourth chamber. The right side heart carry the deoxygenated blood to the lung that get oxygenated and come back to the left side of the heart that will be pumped by the left ventricle to the aorta to supply the tissue with oxygen and nutrients. And the pressure on the right side of the heart is usually 25 to 30% of the left side. So if the pressure in the left ventricle is 100, usually the right ventricle in normal people is around 25 to 30 millimeter mercury. That has an implication in some diseases. For example, this is one of the most common cardiac lesions that might present to the ER with heart failure. We call it high output heart failure, where the QB, which is the blood flow to the pulmonary circulation, in relation to the QS, which is the blood flow to the systemic circulation, is high. So from the VSD at the beginning, the pressure is high in the pulmonary artery, the resistance in the lung is high. After a few days to weeks, sometimes 2 months, the resistance comes down and more blood will be shunting from left to right. And this shunt will be even more than the amount of blood going to systemic circulation. That huge amount of blood will go to the lung and cause congestion and heart failure symptoms in those patients. On the contrast, so this is another example of shunt lesion, where this is an AV canal or AVSD lesion, where there is an AST prime and VSD prime, and VSD. These two lesions will cause more shunt to the lung, and the patient will present with heart failure like the first one. And this is how the X-ray looks like. Usually the heart is large and big, and the lung is congested with pulmonary edema. In contrast to that, cyanotic baby, what we call blue babies at the past, their QP to QS is low, which means that the blood that goes to the lung is less than the blood that goes to the systemic circulation. So there is the most common example is tetralogy of Fallot, where there is a blood going from the right ventricle to the left ventricle, then to the systemic circulation. That creates a right to left shunt, which make the patient cyanose. So the saturation usually in the high 70s to low 80s. This is the X-ray, typical X-ray of tetralogy of Fallot patient, where we call it a boot heart. The right ventricle is hypertrophied, which push the left ventricular apex or the heart apex to the slightly upward and to the left side. Another group of cardiac patients with congenital heart disease that might present to the ER with cardiogenic shock is the systemic cardiac output limitation. That like lesion in the left side, outflow with coarctation or aortic valve stenosis, they usually will present with poor perfusion to the lower part of the body. The cardiac function will be depressed. Later stage, the lung will be also congested, and they will present usually with cardiogenic shock. In ER, it's very important for the ER doctors to know what is the acceptable saturation for a single ventricle heart. This is important because usually the patient is okay with saturation of 70s with this lesion. We call it cyanotic heart disease, single ventricle heart, like this one. This, for example, this heart is a tricuspid atresia. There is no tricuspid valve. So all the blood goes to the left side, and from the left side it pumped the aorta. And in the OR, we created a shunt between the subclavian artery and the pulmonary artery. Nowadays, they do more of aortic to the pulmonary artery. They call it central shunt. But anyway, the end result is the same, that the blood goes to the pulmonary circulation, and the saturation usually in the 70s, 75 to 80, sometimes a little bit above 80, but for sure not acceptable to be less than 70. So if you have patient with 70 saturation and a BT shunt, you should accept that as long as there is no acidosis. The second stage of single ventricle is that we connect the superior vena cava to the pulmonary artery. We ligate the PT shunt, and usually this is called Glenn shunt, and usually the saturation will improve to the 75 to 85 sometimes. The third stage of final palliation is called Fontan circulation, when it is non-frustrated Fontan, where we connect the IVC to the right pulmonary artery or main pulmonary artery, so the whole blood from the systemic circulation goes directly to the lung without going to the heart. Usually the saturation is above 90, and the patient will have normal saturation at that time. However, in some cases where there is an indication to fenestrate the Fontan, we make a hole in the Fontan circuit here, where a little bit of blood from the IVC or RA will go to the heart, mixing with the good blood that comes from the lung. So the saturation will be slightly lower than normal, usually in the mid to low 80s. The emergency presentation of cardiac disease in pediatrics are either respiratory distress or shock or cyanosis. So those who present with respiratory distress usually tachypnic, retracting, wheezing, and grunting. And the pathophysiology is because of decreased lung compliance, metabolic acidosis, and the usual cause for that is pulmonary edema and hormonal stimulation to some receptors. If they are presenting with shock, usually they are tachycardic, hypotensive, poorly perfused, and usually they are in a low cardiac output status. And this is because most likely of obstructed lesion, decreased contractility, or increased afterload. The third way of presentation is they are blue, cyanosed, and usually it's central. There's also low saturation in the blood, and it's because of mandatory right to left shunt in some lesion like tetralogy of Fallot. In cardiogenic shock, there are a few diagnostic pitfalls. Most of them will present like respiratory distress, which mimic a lot of respiratory diseases like asthma, bronchiolitis, and pneumonia. So ER physician has to be aware of this similarity. They can present with pulmonary edema early in presentation, and this can also manifest as a wheezing and hyperinflation, which also mimic other respiratory disease. If you treat them with bronchodilator, they might get worse. They might be a little bit dehydrated, but if you inappropriately give them extra fluid, if they have cardiomyopathy, they might also get worse. It's not easy to diagnose heart failure in pediatrics because of difficulty to elicit the sign of heart failure, not like the adult, like the raised JVB, which is not the standard. In the pediatric ward, the X-ray is not very sensitive to big cardiomegaly, so sometimes it's very difficult to depend on X-ray for diagnosis. Also, the treatment that we provide in ER can make some children with heart disease even worse. For example, oxygen is non-pulmonary vasodilator, so if you give it to somebody with shunt lesion like a VSD, they might get worse with more pulmonary edema because of pulmonary overcirculation, or they might steal from a BT shunt. So you have to be careful using oxygen in patient with congenital heart disease. Fluid, for example, is common practice in ER for somebody with hypotension. However, if the pediatric patient has a hypotension and heart failure, if you give them fluid, they might get worse and arrest actually. Bronchodilator is also a common drug that we use in ER, but it can make the patient with cardiac disease even worse if you give it to them while they don't need it. Overdiuresis also is not good for patients who are preload dependent. So you have to be careful with some of these practices that we usually do in ER department. So it will be easier to understand cardiac emergency if we categorize them. So we can categorize the patient coming to the ER with cardiac disease either based on age, saturation, or the response to treatment. And in most of the case, you have to combine all the three to make up a diagnosis before the patient gets worse and you don't have the diagnosis. For example, age presentation category, either neonatal presentation, and usually they are sick, crashing, and serious disease. They can be infantile after the neonatal period to 1 year, and usually not crashing. They are usually slowly getting worse. After first year, it can be anything. It can be mild or it can be crashing, like in case of myocarditis. Neonatal presentation usually are duct dependent. For example, limited pulmonary blood flow. For example, pulmonary atresia, critical PAs, severe tetralogy. They will have low saturation. However, they have reasonable gas exchange. So they are not very acidotic. They maintain a good cardiac output. So their blood pressure is okay. However, they have severe desaturation. If they have limited systemic blood flow, they might have a normal saturation, but they are usually in cardiogenic shock, like cases of critical AS coarctation or interrupted aortic arch. If they have limited systemic blood flow with low saturation, this is one of the difficult cases to deal with, like hypoplastic left heart syndrome or severe critical aortic stenosis. There are groups who are not duct dependent. The most common one is the total anomalous pulmonary venous drainage, and if they have obstruction, they don't need prostaglandin. Also, cardiomyopathy is non-duct dependent, and arrhythmia also can present in neonatal period. After the first month of life, the shunt lesion usually present when the resistance in the lung drop. So VSD, ASD, PDA, they can present at any time in the first year. Disease with right to left shunt, like tetralogy follow with cyanosis. Non-critical valvular lesion like PS, AS, and MR. Cardiomyopathy, either primary or secondary, like Al-Kaba, they can present after first month of life. After the first year of life, a small lesion with left to right shunt, like small VSD, PDA, can present at that time. Any form of arrhythmias, cardiomyopathy, infection, all can present at any time. If we divided the patient based on saturation, there are non-cyanotic heart disease where the saturation is normal, like a left to right shunt or cardiomyopathy. There are cyanotic heart disease where the saturation is in the 70s. But remember, the gas is normal. The cardiac output is also maintained, like tetralogy of Fallot. There are mixing lesion where the saturation might not be normal, but also can be normal, like AVSD or total anomalous pulmonary venous drainage or truncus arteriosus. There are patients who might have differential cyanosis, like some forms of interrupted aortic arch where the lower and the upper body are supplied by a different blood saturation. If we divided the patient based on the response to treatment, which is very important to the ER people, there are patients who improve with oxygen supply, like cyanotic heart disease, heart failure if there is no shunt. But there are patients who deteriorate if you give them oxygen, like patients with left to right shunt, VSD, PDA, because you might increase the pulmonary edema. Patient who had a BT shunt, you might give them oxygen and they develop a stealing phenomena where the blood goes more to the lung and less to the systemic circulation. And if they are duct dependent, if you give them oxygen, the duct might even close completely. There are patients who improve with prostaglandin, like the duct dependent lesions that we talked about in the first slide, in the previous slide. But there are patients who deteriorate with prostaglandin, like obstructed type of total anomalous pulmonary venous drainage. So these things that are very important to understand when you deal with patient in the ER with congenital heart disease. So to summarize what we have learned so far, that neonatal presentation of cardiac disease should be taken very seriously. Prostaglandin should be started as soon as possible when suspecting congenital heart disease because it saves lives. Any saturation above 70 with good gas and hemodynamics is acceptable. In fact, sometimes you give oxygen, you might make the patient even worse. But with those patients, you have to call cardiology to confirm the diagnosis. A few slides about heart failure because it's a major issue in ER, and we will see why. Let's start with this. We need to talk about heart failure in a common language. In adult, they use New York Heart Association classification. So if an adult physician in the West talk to an adult physician in the East, and he tell him that the patient is a New York Heart Association stage 2 or class 2, he will know how sick is the patient. In pediatrics, unfortunately, we do have something like that called cross classification, but we shy from using it. And it's very simple and very helpful to know how sick is the patient. So class 1 asymptomatic, class 2 mild, class 3 marked symptoms with exercise, class 4 they are symptomatic at rest. So please start using these classification. Keep in mind when you are in the ER that congestive heart failure can mimic respiratory diseases. Inappropriate fluid therapy can lead to worsening of congestive heart failure. If they are low cardiac output heart failure and you give them fluid, you might kill the patient actually. Inappropriate oxygen therapy might lead to worsening of left-to-right shunt. If they are shunt lesion, like a VSD, and the heart failure will be worsened, so we need to avoid oxygen in those patients. It's been reported that up to 87% of patients with heart failure or children with heart failure were diagnosed, unfortunately, after 3 visits to the ER because of the similarity between heart presentation, heart failure presentation and respiratory disease, which is much, much more common. So in ER, please be careful when you assess patient. Don't forget that might be a new presentation of myocarditis or the new disease with COVID, the MES-C syndrome, that we start to see more and more now. This is I found it very helpful diagram to deal with patient. This is from one of the ER books. So if you have a pediatric patient with heart failure, you do your clinical assessment by a good history physical examination. You send some labs like CBC, ProBNP, and you do some investigation imaging like an X-ray, ECG. You might go for an echo at this stage, and then you call cardiology. Remember, patient with heart failure and pediatric age group, they can be in one of these categories. They can be warm and wet, so their perfusion is good, so they are warm peripherally, but their lung is full of fluids, they are wet. And this type of patient, you need to give them diuretics to dry the lung. They can be warm and dry, and this is the best one, where their perfusion is good and they don't have lung congestion, so they don't need diuretics. They don't need inotropes in most of the case unless their blood pressure dropped. The worst thing is cold and wet patient, where their perfusion is bad and their lung is full of fluid. So these patients need diuretics and need inotropes for blood pressure support. The last category, when they are cold and dry, so their perfusion is bad, but their lung is not wet, not congested. So they don't need diuretics again, but they might need inotropes for pressure support. We'll move now to the ECG and ER. So arrhythmia is not a common problem in pediatric in general, but we have to know a few things about it because we have to deal with patients that comes to the ER with arrhythmia and pediatric age group. So it can present at any age. And remember, please, repaired congenital heart defects, even if small ones like VSD, ASD, they are never normal. They have scar in their heart and they might have arrhythmia at any time of their age. The genetically inherited arrhythmogenic condition can express at any age. So they can be from day 1 to 18 years of age. Neurocomplex tachycardia is the most common. We don't have a lot of ventricular arrhythmia in pediatric. We have a lot of atrial arrhythmias. And remember, computer-generated ECG reports are usually not accurate and create a lot of anxiety and inappropriate hospital admission and consultation. So, general scheme for assessment of neurocomplex tachycardia. If it is less than 200 and there is a P wave, usually it's sinus tachycardia, and look for a reason for that, especially if it varies with breathing and different condition of patient. If the heart rate is above 200, neurocomplex tachycardia with no P wave. If the blood pressure and perfusion are good, try the vagal maneuver or adenosine. If converted to sinus, you can refer patient electively to the clinic. If persist, you have to call cardiology for treatment and workup. If they have neurocomplex tachycardia with no P wave, they are not stable with low blood pressure, poor perfusion, you might need to do immediate synchronized cardioversion, admit to the ICU and involve cardiology. For a wide complex tachycardia, it could be regular or irregular. The regular wide complex tachycardia, it could be stable VTAC with good blood pressure, and you need to consult cardiology. It's not a very urgent matter. If they are having regular VTAC with shock, where their blood pressure is down, perfusion is low, you need to do synchronized cardioversion. It might be wide complex regular, but it's not VTAC, it's an SVT with apparency, where the wide complex, the QR complex is wide, and you might consider adenosine in this case, but you need to consult cardiology as well. If the wide complex is irregular, it could be atrial fibrillation with accessory pathway, and in this case, you need to involve cardiology immediately. Syncope is another problem with rhythm issues and cardiac problem that present to the ER. And it's very important to obtain a very detailed event history, family history, physical examination, and ECG. If there is an abnormal physical examination or any red flag in the history or any abnormal ECG, you refer to cardiology. If there is none of these things and there is no alarming event, you might be just reassuring the patient. But if there is any alarming positive family history, you need to involve cardiology. And if the symptoms improve after your initial management, you just continue to support the patient. And if not improving, you might at that time refer to cardiology. Chest pain is also another complaint of patients that come to the ER. And you need to differentiate between benign and serious chest pain. First of all, chest pain in pediatric, in most of the cases, are benign, localized, sharp, exaggerated with respiration, and it usually is caused to muscular skeletal problem, and usually just need analgesia and rest. If it is diffused, suprasternal and squeezing, exaggerated with exercise, that might be a cardiac, which is very rare, but it can happen in pediatric. You need to do an ECG to look for ischemic changes. You might need to do a cardiac enzyme, and you need to call cardiology to work the patient up. And to be able to manage patient, I think nowadays it's the time for all ER to learn how to do ultrasound for the cardiac patients. And it's not difficult. In fact, it's now required in fellowship and training since 2010. The focus is recommended as a core application, and it can rapidly assist symptomatic patient to identify pericardial effusion, cardiac standstill in case of arrest, evaluate the function, and assess the volume status of inferior vena cava in cases with hypotension. It's not difficult to learn how to use these ultrasound probe or echocardiography. There are many forms of them, many size. And we do look at the heart from different angles. So parasternal short, parasternal long, apical, and subcostal. And these 4 areas will give you a good idea about the heart function, size, if there is any fluid around the heart, any cardiomegaly, any problem with the function. This is a patient with pericardial effusion that need an intervention. And it's easy to diagnose by ER physician using any ultrasound probe. X-ray in ER for a cardiac patient has problem because it's not very sensitive, although the specificity is better than sensitivity. For example, a big heart in AP or PA view with congested lung is usually a marker for a cardiac problem. But if the heart is big in AP, you have to make sure it's also big in lateral, because if you draw a line anterior to the trachea, and this line intersect with the spine below the diaphragm, this is not a cardiomegaly. This is the panel on the left side, panel A. Panel B, this is a patient with cardiomegaly. If you see that the line drawn in front of the trachea intersect with the spine above the diaphragm, which means this heart is big in both AB and lateral. And this is one example. You see this heart is big on the AB view or BA view, but when we did the lateral, the line that we draw in front of the trachea intersect with the spine below the diaphragm, which means this patient has no cardiomegaly, and what we are seeing is just large normal thymus at this age of patient. While this patient was also a large heart or a big heart in the AB, when we did the lateral and that line we draw in front of the trachea intersect with the spine above diaphragm, which means the heart is enlarged in both AB and lateral, which confirmed the diagnosis of cardiomegaly. This heart is also big in AP, and when we did ultrasound, we found big effusion around the heart, and you can see the panel D or the picture D with the drain inside the pericardial space that drained the effusion that was on image C. And you can see the cardiomegaly is almost gone. Rare but serious heart size is what we call wall-to-wall heart. Can happen in newborn. It's the most common cause for it is Epstein tricuspid valve, but it can happen with any right side heart problem. It also can happen with some sort of extreme cardiomyopathy, especially hypertrophic cardiomyopathy. Not all cardiomegaly is because of the heart. You can see this big heart in the AB X-ray. When the patient has a CT scan, it was found to be a mass in the mediastinum, and it tend to be teratoma, while the heart size is actually normal. So this is a typical X-ray for patients who come with cyanosis, and you can see the boot shape. This is a tetralogy of fellow patient, where there is a upward of the apex of the heart, and there is no bulging of the pulmonary artery due to a slightly small pulmonary artery because of the tetralogy of fellow. Patient can present to the ER with frequent cough and swallowing problem. And when you do an X-ray, you find this indentation on the trachea and the AP. It also happens on the lateral. And this should raise the suspicion of vascular ring. If you do a barium study, you might see the impression on the posterior wall of the esophagus. You can confirm the diagnosis by MRI, where you can see the patient having right aortic arch with apparent left subclavian that goes behind the esophagus, causing complete vascular ring and causing symptoms of the patient. That was the last slide. I hope it was informative, and I hope you enjoy the rest of your meeting. Thank you.
Thank you very much, Dr. Abdullah. And I hope you are with us. If you can answer, there is a few questions here. One question here is mentioned that how can I give adenosine in emergency department for narrow complex SVT who is on propranolol?
Of course, you can give adenosine even if he's on propranolol if there is a SVT that's not responding. So and usually we give it as much as we can close to the heart and push it fast. And if he did not respond to 0.1, you go directly to 0.2 per kg to go to the high dose. Usually they like to respond to high dose close to the heart. So the answer is yes, you can always give it.
Thank you. Dr. Abdullah, also there is another question. Sometimes with those recurrent SVT coming to the emergency, and usually according to their history before they respond to amiodarone, still you have to use the first line adenosine, or you will go ahead with amiodarone, especially from their notes in the previous attacks of SVT, they never respond to adenosine. First dose, second dose, third dose, doubling the dose. So do you recommend to start amiodarone right away, or again follow the guidelines?
If they are non-responder to adenosine and they are stable enough to give them infusion, amiodarone can be given in two ways. You can give a bolus of 5 to 10 milligram per kg over 10 to 30 minutes. Then you follow it with infusion, or you can give infusion if the patient is stable. People use these two ways. So if the patient is known to be non-responder to adenosine and he responds to amiodarone and he is stable enough to be treated, we call it medical cardioversion by amiodarone. You can do it, so no problem with that, of course.
Dr. Abdullah, another question here. If the patient is a long QT syndrome and asthmatic, how can you treat this child?
Yes, it's difficult. It's not only the long
status asthmaticus, for example.
Yeah, it's not only long QT. Most of the tachycardia, they don't tolerate. The asthma patients, they don't tolerate the beta blocker actually. So it's a difficult situation. Those type of patients, if they are really in bad asthma, you still can give them Ventolin, and you just try not to overdo it, because we tend to give Ventolin in the ER. And we overdo it sometimes. So if they need it, they are in asthma, you cannot prevent them from having the Ventolin, even if they are having arrhythmia, including the long QT. Because I expect long QT patient to be on long-term treatment, either beta blocker or mexiletine, or they maybe if they are bad, they could have an ICD or even surgery for that. So if they need the beta blocker, the Ventolin, you give it, but be careful. Use small dose and don't overdo the treatment.
Okay, another question here. What is the major differences between VT and SVT with aberrancy that can be detected easily in emergency?
Yeah, it's sometimes not easy, especially at low rate. Usually, the SVT with aberrancy is a high rate, above 220. But VTAC is usually less than that. So this is the most common difference is the rate. So the higher rate is usually in favor of SVT with aberrancy. Lower rate is more with VTAC. It's very unlikely to have VTAC in children. Yes, it can happen, but it's very unlikely. So that's the major difference you can use.
Another question: can MI occur in children?
Again, it's very unlikely, very rare. It can happen. I have seen it only in patients with familial hypercholesterolemia, and sometimes in patients with Kawasaki if they have huge aneurysm that clotted and closed the coronary artery. So these are the two known cardiac disease that present with MI in children. So hypercholesterolemia, familial hyperlipidemia, and Kawasaki disease with coronary involvement. Yes,
Very
it can
high.
happen.
Yes. Another last question. Who can give amiodarone, cardiologist or emergency physician? If you are in a periphery and this patient presented, he didn't respond to 3 doses to adenosine, can I give amiodarone?
Of course, if he's in an area where there is a good monitoring, blood pressure and heart rate, and he needs it, it can be given in ER and the ICU. So if it's better to be in the presence of cardiologist in the ICU, but the ER physician are usually competent enough to give and monitor those patients if they really need it.
Thank you very much, Dr. Abdullah, for this informative lecture, and wish to see you again in our future courses and conferences. Thank you.
Good. Thank you very much.
Our next speaker now is Dr. Abdullah Tamimi. Dr. Abdullah Tamimi, he is a pediatric emergency consultant and toxicologist at King Fahd Medical City. Dr. Abdullah will talk about advancement in poisoning management. And Dr. Abdullah, you can start, please.
Thank you for being here today. We are excited to share a new strategies and approach that will be greatly improve the management of common toxic exposure. These methods are backed by latest evidence of over greater effectiveness, shorter duration of treatment, fewer side effects, and reduced error. In this session, we'll focus on addressing the challenges related to acetaminophen toxicity and its treatment regimen. We'll discuss innovative technique and protocol that make the process easier and more effective. Our goals to provide you with practical information that will benefit everyone, resulting in improving outcome with fewer side effects and mistakes. Finally, we'll present a research systematic review that adds valuable insights of this field. Thank you for joining us, and we hope to find this session informative and helpful. As you see here in our title, Advancement in Poisoning Management and Refining New Strategies for Common Toxic Exposure. As we know, there is many toxic exposure, and there is new strategies now for treatment, for approach. There is many things, so we are decided to present one of the most common of them. the most common exposure agents, acetaminophen or paracetamol, which widely used for pain relief and fever reduction. This is the most leading cause of the hospital presentation and admission due to deliberate self-poisoning and accidental overdose. As you know, acetaminophen overdose, the main cause of acute liver failure. In acetylcysteine, used as first-line therapy since the 1970s. Acetaminophen or paracetamol overdose, predominant cause of acute liver failure in North America, Europe, and Australia. This acetaminophen is one of the most common drugs or toxicity that brought the patient to the emergency room. Over 300,000 hospitalizations annually in USA due to acetaminophen overdose. Up to 42% of cases of acute liver failure attribute to acetaminophen overdose, which very large numbers and significant. The NAC or an acetylcysteine plays a crucial role in protecting liver from toxic effects of acetaminophen. It helps to restore glutathione levels, support detoxification process, and NAC administration has been associated with improvement patient outcome and reduced mortality rates. And as we know, there is various regimen. There is traditional regimen, which is more commonly used now in our society, our country, and North America too. But there is a new regimen try to overcome the complication and side effect. As you see here, there is various regimen now is available, exist for NAC administration in acetaminophen overdose. There is need for new regimen that are equally and more effective and have shorter duration, fewer side effects, and reduce complication and medical errors. As the old regimen 3-bag regimen for IV regimen for treatment of acetaminophen toxicity, it's a little bit complicated, different duration, different dose. Conducting trials, dose ranging studies is essential to identify the optimal NAC regimen, which is very important. Need more study, need more trials, need more systematic review to see the difference and to looking for the advantage, disadvantage, and more appropriate regimen for treatment for acetaminophen overdose. The goal is to find regimens that over comparable, improve effectiveness while addressing limitation of current regimen. In acetylcysteine, as we said, treatment first choice, NAC remains the antidote of choice, effective in preventing hepatotoxicity if administered within 8 to 10 hours of overdose, and the protection almost reach 100%. There is two ways to give in acetylcysteine. The first way, oral administration, which started by 140 milligram per kg loading dose, followed by 70 milligram per kg every 4 hours for total 17 doses. This is modality of treatment coming from research for patients have exposed to 15 grams of acetaminophen, and they found to restore the depleted glutathione for these cases, very huge dose of or toxicity, and also give it every 4 hours as this most likely common average of the half-life of the acetaminophen. There is other modality or other way to give in NAC, it's IV administration. As we mentioned before, there is too many modalities or ways to give in the IV NAC. The first one, as you say here, traditional 3-bag methods, which commonly used in our countries, North America, Europe countries, Australia too, which is started by 150 milligram per kg over 60 minutes, then 50 milligram per kg over 4 hours, then 100 milligram per kg over 16 hours. What we'll see here, there is different doses, different duration, and different dose. that make it complicated and maybe misunderstanding by physician, maybe is make the pharmacist difficult to preparation and also to follow this protocol. And that means will be increased risk of errors, risk of complication, risk of mortality and side effect. FDA approved 2-bag regimen, which usually start by 200 milligram per kg over 4 hours, followed by 100 milligram per kg over 16 hours. If you're looking to this regimen, that mean will give 50 milligram per kg per hour. If you're comparing this dose with the previous one, the old one, traditional one, the traditional will give 150 milligram over 1 hour. That means the total dose 300 milligram, half of it will give 150 milligram over 1 hour. That will increase risk of the errors, risk of the complications, side effect, even volume overload and electron disturbance, mainly in the pediatric. And the other regimen is the dose base. That means will eliminate and increase safety window or safety margin of treatment. If there is any mistake, we can have also safety margin and decrease side effect and complication. The third one, single bag NAC infusion, dosage and duration, 100 milligram per kg of NAC in 1000 ml, 5% dextrose over 20 hours. We'll come back again to the traditional 3-bag regimen. It involved 3 separate infusion with varying doses, as we mentioned, different dose, different volume, different times, which it's a little bit complicated, especially if the center is not well established and is not have experience for the physician, for the nurse, for also pharmacists. A study found that 33% of the patient experienced medical errors, including there is anaphylactic reaction, there is GI, electron disturbance, many things. 18% of or more had therapy interruption exceeding 1 hour. 13% received unnecessary therapy, raising concern due to potential serious effect reaction. In retrospective study, we have two new regimen, old regimen. The new regimen, they found 38% of the patients experienced medical errors, and alternative regimen, this is for alternative regimen. The old regimen, traditional regimens, reaching up to 60% side effect and medical errors. Therapy interruption occurs in 8% of the patient, exclusively those over 69, about 70 kg, needing more than 30-gram dose initially prepared. That means once the weight is increasing, the dose will be increased, the complication will be more, and side effect will be more. Why? Because we're exposed to very large, huge dose of N-acetylcysteine. And we didn't know if the patient obese will calculate according to ideal weight or the real weight. This is very important. Lower therapy interruption rate compared to 19% in traditional regimen. Identified one severe anaphylactic reaction managed with diphenhydramine and reduced infusion rate. I have one story with not with me, but in our center. There is one patient, 18-year-old, healthy boy. He's taken acetaminophen or paracetamol for suicide attempts, present to the emergency in the hospital in the periphery, and they started N-acetylcysteine according to the traditional way. Then after that, the patient started to have an anaphylactic reaction. They start to manage the patient, but unfortunately, the patient passed away, expired. What's the sad story about this one? After that, discovered there is the patient already is not taking toxic dose. One. The other thing, there is wrong preparation from the pharmacy. The third one didn't have safety margin or safety to eliminate any risk of that. Also, we didn't know about the rate that used for this patient from the nurse, because there's many different ways. The sum of the books or references mentioned can be given over 20 minutes. Some of them will be given over 1 hour. All these increase the risk of reaction. Expected benefit flu regimen. Enhanced treatment efficacy with reduced duration therapy. Minimize side effect and complication. Decrease medical errors in NAC administration. New regimen aim to optimize treatment and improve patient outcome in acetaminophen overdose cases. The focus in balancing effectiveness, safety, and efficacy. This is very important. When you start with treatment, you have to take and make balance between effectiveness, safety, and efficacy. For me, as a medical toxicology consultant, if you have call from periphery hospital, usually I didn't like to start high dose 150 milligram over 1 hour, because I know maybe there is something wrong, maybe preparation will give volume overload, something like that. So I usually start the alternative regimen, like 200 milligram over 4 hours. That means 50 milligram per kg per hour, which is very effective and very safe, and we balancing between effectiveness and also the safety. Current IV NAC regimen, FDA approved regimen, 300 milligram per kg per dose, which administered over 24 hours, as you mentioned, 300 total dose, will give 150 milligram, as you mentioned. This is the traditional way, 3 bag. 150 will give over 1 hour, which is very strange. It's very, maybe will make the people anxious and difficult to calculate and prepare. 3 separate IV infusion with unique concentration rates, lack of randomized controlled trials or dose ranging studies to establish optimized regimen. Medication errors in administration, such as incorrect dosage and infusion rate. Also, we will face these issues and problems in this regimen. Now we'll go to other regimen, as you mentioned before, 2-bag IV NAC regimen. It's very nice. Emerging evidence suggests its safety and effectiveness. Yes, we have some studies and some trials. They mention it's almost same effectiveness and also more safe, associated with fewer side reaction compared to traditional 3-bag regimen. Simplified alternative to the current regimen. It's very simple. It's not complicated like before. And this is, I feel, more comfortable and more safe for the patient than old one. 2-bag regimen study. This is what's called 2016 over 20 hours regimen. As you mentioned before, it's 200 milligram dose of the dose or 200 milligram per kg IV over 4 hours. That means will give 50 milligram per kg per hour. Second dose will start 100 milligram per kg IV over 16 hours. That means 6.25 milligram per kg per hour, which is very nice. Anaphylactic reaction occurred in 4.3% of the patient in modified regimen versus 10% in the traditional regimen. Severe reaction 0.5 in modified regimen and 2.5% in traditional way. No significant difference in GI effect in hepatotoxicity between 2 regimens. That means effectiveness almost same, but the safety is more with 2-bag regimen. There's what's called also variable duration regimen. SBISTER 2016, you will start by 200 milligram IV over. This is why you call it variable, 4 to 9 hours, adjusted based on the time from ingestion. If the patient presents early, you can start 200 milligram per kg over 8 hours, but if he's late, maybe we'll start 200 milligram per kg over 4 hours. Follow-up infusion, 100 milligram per kg IV over 16 hours. Treatment discontinued early if acetaminophen concentration below toxicity threshold or normal liver enzyme at 24 hours. Early discontinuous, they found early discontinuous in 64% of the patient due to low risk acetaminophen concentration. Adverse reaction in 35% of the patient. GI effect alone in 26%, cutaneous hypersensitivity in 8%, severe hypersensitivity with hypotension in 0.5%. High adverse effect rate, the patient completing full regimen comparing that to those discontinuous early. It's about 84% versus 28%, which is significant. Hepatotoxicity developed in the patient treated more than 12 hours post-injection if you delayed to start NAC. Medication errors related to infusion rate and premature discontinuation. Conclusion from the studies. 2016, the modified 2-bag regimen may reduce the incidence of anaphylactic reaction without compromising safety concerning GI effect and hepatotoxicity. Spester 2016 proposed adjusting treatment based on risks assessment with potential benefit in reducing unnecessarily exposure to acetylcysteine in low-risk patients, demonstrating possible balance between efficacy and minimized adverse effect. As you mentioned, now we have balance, we're making balance between benefit and side effect. One bag IV NAC regimen proposed as potentially simpler and more efficient treatment option. Further exploration, yes, need more exploration needed to assess safety and effectiveness, either by trial research or by systematic review, and we'll see comparing between 3-bag, 2-bag, and 1-bag, and we'll see which more safe, which more effectiveness, and we'll select the most proper and safety and effectiveness for the patient. Maybe improve patient compliance ease monitoring. 1-bag IV regimen, as you mentioned here, the typical concentration is used 200 milligram per kg loading dose in total volume that sustain over 21 hours period. This contrasts with traditional 3-bag regimen, which commonly include 150 milligram per kg loading dose over 1 hour, followed by 50 milligram per kg infusion over 4 hours. The final 100 milligram per kg infusion over 16 hours, which is a little bit complicated, different duration, different doses, and volume also changing and increased risk of complication and infant mortality rate and anaphylaxis. Infusion is given continuous over 24 hours, simplifying the administration process by eliminating the need of multiple bag exchanges. Advantage 1-bag, as you mentioned here, reduced complexity, one important, enhanced safety, and reduce risk of contamination and administration errors, improve compliance, very important. Clinical consideration and efficacy. Efficacy studies suggest that 1-bag regimen is effective in treatment of systemic toxicity with outcome comparable to those of traditional regimen. However, specific comparative clinical trials data will be necessary to confirm equivalent efficacy across all patient population. The safety profile is expected to be similar to traditional regimen, assuming correct dosing and administration. Monitoring for adverse reactions such as anaphylactic reaction remains essential. Patient monitoring, continuous monitoring liver function test should be also assess liver acetylcholine level frequently. Clinical status is necessary to assess effectiveness, treatment, detect any adverse reaction early. Also, because we are working in the same field, we have specialty in toxicology, we are now starting to fill some gap to evaluate safety and efficacy of different intravenous acetylcysteine regimen for acetaminophen poisoning. Comprehensive network meta-analysis. Now we start a systematic review to see and comparing between one single bag, 2-bag, 3-bag, to see which more effective, less complication, and to sharing, not to fill, to sharing to fill the gaps in treatment and in acetaminophen overdose and which better modality for treatment. Conclusion. To definitively determine the optimal IV NAC regimen for treating acetaminophen poisoning, we have initiated systematic review, as you mentioned, and are conducting further clinical trials. This effort aims to validate and refine treatment protocol based on robust scientific evidence and clinical efficacy. Thank you for your attention. Any questions?
Thank you very much, Dr. Abdullah, for this overall review on pediatric toxicology and exposure to toxin. We will leave the question to the end. Now, our next speaker is Dr. Mohammed Al-Awain. Dr. Al-Awain, he is consultant in medical genetics, and he's the chairman of the Department of Medical Genetics at King Faisal Specialist Hospital Research Center. Dr. Al-Awain will talk about metabolic disorder in children. Dr. Al-Awain, you can start, please.
Thank you very much. I would like to thank the organizing committee, Dr. Mohammed Al-Faifi, and all the team for the invitation. Today, I will be talking about the emergency care for common metabolic disorders. As you know, metabolic disorders can be challenging management-wise, and I will try to make it as simple as possible. There are too many metabolic disorders that are caused by specific enzyme deficiency or transport protein defect. More than 500 we know. And all of them, the pathogenesis stem from either excessive accumulation of substances normally present in small amounts, or deficiency of critical intermediates or end products in the metabolic pathway. As you can see, here is the substrate and here is the product. If the enzyme is working, everything is fine. Once you have a deficient enzyme, automatically there will be substrate accumulation, which can be toxic, or you can have deficiency of a critical product. We classify inborn nerve metabolism into organic acidemia. This is a very important group. Amino acidopathies, which involve amino acids, urea cycle defect, also another important group. And then disorders of carbohydrate storage, glycogen storage, lysosomal storage, fatty acid oxidation defect, gluconeogenesis, mitochondrial, and so on. The most important presentation that we will discuss today is the acute. You can have acute presentation with hypoglycemia, hyperammonemia, and metabolic acidosis. These three actually are the most important for the emergency room staff. It can come as a neurodegenerative picture with seizures, brain malformations, hypotonia, and so on, or it can be muscular with cardiomyopathy, skeletal myopathy, and so on, or it can be slowly progressive storage-like with hepatosplenomegaly. It could be also involving the CNS, the bone, and so on. Now let's go first to the common disorder and common presentation. Not unusual in the emergency room, you face a child who is encephalopathic, and the differential diagnosis for encephalopathy is very wide, including inborn error of metabolism. It can be caused by urea cycle, by organic acidemia, by maple syrup urine disease, which is an amino acid metabolism defect. Now, continuation for the presentation. The typical symptoms with encephalopathy include lethargy, poor feeding, apnea, tachypnea, recurrent vomiting, And it can be associated with metabolic acidosis and or hyperammonemia. This is a child who presented with encephalopathy, comatose. This is due to organic acidemia, particularly propionic acidemia. And if you look at the brain MRI, it shows basal ganglia infarction and metabolic stroke, which is seen in this type of diseases. Another child undergoing peritoneal dialysis who is encephalopathic because of very high ammonia level. And hypoglycemia can be caused by several disorders or several group of disorders, including glycogen storage diseases, gluconeogenesis, fatty acid oxidation defect. I think hypoglycemia is easily recognizable because any child who is sick will have immediately a glucose check done, and that can be easily recognizable. And also easy to manage because I think you guys are really good with this. Sometimes patients can present with hepatic presentation, with jaundice. And it's an acute presentation because they can be really sick and they need relatively urgent intervention. The group that cause this are galactosemia, hereditary tyrosinemia, and sometimes neonatal hemochromatosis, although uncommon. There are too many liver diseases, but they are outside the scope of metabolic diseases. The two main treatable conditions that come to our mind are galactosemia and tyrosinemia. This is a child who's severely jaundiced, having severe ascites, and his liver function showing fulminant hepatic failure, very critical with tyrosinemia. A treatment called NTBC can reverse all these symptoms. How do we make the diagnosis? We'll try to make it very simple. There are two main levels of diagnosis. One is biochemical, and we mean by biochemical all blood tests that measure all metabolites or basic workup, and sometimes enzyme assays, or molecular, which is the DNA. And honestly, the DNA analysis or the molecular diagnosis has dramatically changed the diagnosis or the diagnostic dilemma for many patients. The main problem with the molecular diagnosis, it takes time. So if you look here, this is the DNA. It gets transcribed to RNA and then protein and then the substrate and product. The DNA, if you sequence the DNA here, then this is the molecular diagnosis or DNA analysis. We normally don't do RNA at the bedside. It's usually done on a research basis. So this part I will skip. Enzymatic assay or protein analysis usually left for the clinic, in the metabolic clinic, and usually it is relatively cumbersome, not an easy test to do. And you can measure other things like the substrates and the products by the either routine tests like ammonia, metabolic acidosis. You can measure amino acid analysis. You can do the metabolic screen, urine organic acid analysis by this machine, or plasma and urine amino acid analysis by this machine, or using tandem metabolic screen, another machine that is used to measure different metabolites to reach the metabolic diagnosis. There is a battery of tests that we normally do, including the blood gas, glucose, urinary ketones, plasma ammonia, renal function, liver function, uric acid, CK, lactate and pyruvate, blood carnitine level, ketones, we can specify them like beta-hydroxybutyric acid. And also we do, as I said, the urine organic acid and amino acid analysis. Newborn screening has actually opened doors for early diagnosis. Many patients are diagnosed with PKU, with several metabolic diseases early on before even symptoms start. Occasionally, a baby is discharged from the nursery and then all of a sudden present on the 3rd, 5th day with severe metabolic acidosis or high ammonia. And when we go back to the metabolic screening, we may find the clue to the diagnosis. Now, how we acutely manage these cases? There are basic principles that I would like you to understand. Number one, these patients, they require fluid. So they need a normal saline bolus at the beginning. Number two, they need high glucose infusion to stop catabolism. Because of the stress that they are going into, their own proteins in the muscles is getting broken, and as a result, they go into catabolic state, which aggravate the metabolic problem. So one way to do this is to give them high glucose with vigorous hydration, and this is very critical. And that's why we use more than at least dextrose 10%, and sometimes more, depending on the line that you have, at least 1.5 maintenance. This is basic, intervention, especially in the first 24 hours. The first 24 hours, we keep the patient in PO. And then depending on, are we dealing with organic acidemia, for example, or are we dealing with urea cycle, we will go through this. So if we have high ammonia, for example, we have to think about scavengers like sodium benzoate, phenyl butyrate, and so on. If we are dealing with urea cycle, then we give arginine. IV arginine is a must. For organic acid ureas, we give IV carnitine, and for metabolic acidosis, we always give sodium bicarb infusion. So long-term management, of course, here we will intervene in the clinic with a special diet, with oral medication. I don't think it's the place for the emergency room, but we tend to focus on this in terms of long-term therapy. We also use cofactors like vitamin B12, vitamin biotin, for example, and so on. Let's give you now specific disorders one by one. We were talking about group of disorder, how to manage in general. The most common disorders, I will say, are organic aciduria. Two main important ones in Saudi Arabia, methylmalonic and propionic acidemia. If you receive a patient from the south, then propionic acidemia is more common. From other parts of the country, from the west, the north, and so on, the methylmalonic is probably more common. If you are dealing with somebody, now organic aciduria, they present two main presentations. Severe metabolic acidosis, that's number one. It's a must in their presentation, and high ammonia sometimes. MSUD, they come encephalopathic with very high leucine, but normal, usually normal labs, no acidosis, no normal ammonia. Urea cycle, mainly high ammonia, and normally they don't have acidosis. They tend to be alkalotic, actually. And the common example are arginosuccinic, citrullinemia, OTC, and CPS. All of them, their management are very similar. There is one group called biotinidase. There is one disorder called biotinidase. It is treatable condition. They can come with seizures. That's why they can come in the emergency room. They come with skin rash. They can come also with optic atrophy, hearing loss, but mainly skin rash, hair loss, and seizures in particular. And they are easily treatable with high-dose biotin. This is the biotin cycle. I will not go through it that much, but mainly the biotinidase is very important to release biotin from the proteins and other products, so it can be freely it can be free used by the enzymes in the body. This is a skin rash, severe skin rash, difficult to treat without biotin in children with biotinidase deficiency. Homocystinuria, I don't think it will be an acute presentation unless they come with a stroke. They can come with a stroke because they have thromboembolic phenomenon related to high homocysteine. We have to measure homocysteine in their blood to make the diagnosis. And if homocysteine is very high, it tends to be diagnostic. Remember, they have also lens subluxation, normally downward compared to Marfan, which is upward. They tend to have mental also deficiency, mental subnormality compared to Marfan. Marfan, usually they have normal intellect. GSD type 1 is the most common cause of glycogen storage disease. They tend to have severe hypoglycemia, usually before feeding, significant hepatomegaly, and they require NG feeding and a special diet by our dietitian, and they can come to the emergency room as well. Pompe disease, they can come with severe hypotonia, cardiomyopathy, high CK, and they require enzyme replacement therapy. That's another disease. Now let's speak about hyperammonemia. This is a must. You guys have to know this in the emergency room. First of all, as I told you, that we have to give high dextrose with the high hydration with dextrose 10% to prevent catabolism. We have to rapidly clear ammonia with ammonia scavengers like sodium phenyl butyrate, sodium benzoate. And if ammonia is very high, we use sometimes dialysis, either peritoneal dialysis or hemodialysis. If we are dealing with urea cycle, we use arginine. And if we are dealing with organic acidemia, carglumic acid, or also called carbaglu, can be also used to treat hyperammonemia in these cases. We tend to give them emergency letter once they are diagnosed to help the emergency physician how to recognize the disease and how to treat. So they need supportive therapy with IV fluid, high dextrose, keep MPO for the first 24 hours. Sometimes they require intubation and ventilation. We have to, as I said, stop protein intake in the first 24 hours. Dextrose 10%. If ammonia more than 200, give arginine, benzoate, phenyl butyrate. Give carbaglu for organic acidemia. If more than 400, start dialysis, prepare for dialysis. Now, let me give you some examples, because I think there are 3 examples I will give you here for the next 10 minutes or so. They are really good examples, and it will walk you through how to make diagnosis and management. You are evaluating a neonate in the 3rd day who started poor feeding and then went into coma. Dehydrated, hypothermic, hypotonic, with appendicular hypertonia. His white blood cell on the low side, 3.8, hemoglobin 11.6, platelets on the low side, 58. Sodium 135, chloride 101, CO2 7, this is bicarb. Glucose very low, 1.1. pH acidotic 7.1 and bicarb 8.1. Ammonia 278 and ketones 3+. So the first question, what's the primary metabolic problem? Look, if you look here, there is severe metabolic acidosis. And bicarb is very low. And ammonia is also high. So there is a combination of two. This is typical of organic aciduria. And in Saudi Arabia, you are dealing most likely MMA, methylmalonic, or propionic. As I said, if you are dealing with a family from the south, you are dealing with propionic, and otherwise MMA is more common. They tend to be ketotic, and they may have hypoglycemia, they may have hyperglycemia, and they may have also normal glucose. Now, the second question, what is there acidosis? Yes. And what's the anion gap? Many times you guys forget to do the anion gap. Here, 135 minus 101 minus 7. Here, it would be probably 27 or so. So it is typical high or elevated anion gap. Because if you deal with a normal anion gap with metabolic acidosis, you are dealing with either renal loss or chloride loss. And there is one disease that is very common in Saudi Arabia. It's called osteopetrosis with renal tubular acidosis. It can cause, they can present with bicarb of 12, but normal anion gap. And in that case, if you do bone X-ray, you will find the osteopetrosis. So the metabolic diagnosis, as I told you, it's an organic acidemia. Now, here we will do immediately tandem metabolic screen. We will do plasma amino acid, and here we will find something called C3 carnitine will be very high. And we will find 3-hydroxypropionic high if we are dealing with propionic acidemia, or methylmalonic acid high if we are dealing with methylmalonic acidemia. How we treat? Immediately we will give a bolus of normal saline, start D10 with appropriate electrolytes, and at least 1.5 to 2 or double maintenance, give sodium bicarb. You can give 1 to 2 milli equivalent or millimole per kg, and you can repeat until at least you push the bicarb toward 14, 16, and you add 40 to 80 millimole per liter in the IV fluid, depending whether you have a central line or no. Normally, this patient will go, of course, to the ICU. For the ammonia, usually ammonia, here in this case, ammonia will respond to the hydration. We will give IV carnitine here, by the way, because we are dealing with organic acidemia. We will give 50 milligram per kg per dose every 8 hours, total 150 per kg per day. And we can give carbaglu because we are dealing with organic acidemia. Carbaglu, it will strengthen the urea cycle because it is suppressed in organic acidemia. And you normally, with this intervention, ammonia will come down. We normally don't require dialysis here. If you have, rarely, you may have refractory metabolic acidosis. That can be an indication for dialysis. They usually respond to management immediately. So this is the first case. The second case, 3-day-old, quickly profound hypotonia, coma, and cardiorespiratory collapse, intubated in the emergency room. Here, white blood cell is okay, hemoglobin is fine, sodium, chloride, CO2, anion gap is fine, glucose is okay, slightly alkalotic, ammonia is very high, more than 1,000. So this is typical of urea cycle. And urea cycle, there are two kinds. There is early defect and late defect. Early defect, they tend to have early presentation like the 3rd day of life. And they tend to have very severe hyperammonemia like this, more than 1,000. Here we can be dealing with OTC because this is a boy, or it could be also CPS, which is boy is the OTC is an X-linked, and CPS is autosomal recessive. Here the management will be dialysis, of course, immediately, and they will require also scavengers with arginine, IV aminol, the sodium phenyl butyrate and sodium phenyl acetate. And many times they will go into cerebral edema. Sometimes some of these children are very hard to treat, and they may die because of the severe hyperammonemia. They may require liver transplant because even if we treat them, they will come back again with severe hyperammonemia. For the late defect, which is arginosuccinic and citrullinemia, they usually respond nicely to arginine. Normally the ammonia is less than 1,000, but they normally respond high to arginine, and they may require also the scavengers with sodium phenyl butyrate and phenyl acetate, and they require also high dextrose with high IV fluid, the same. They don't require bicar, they don't require carnitine. So we told you what is the primary metabolic problem here. We told you the anion gap is normal. We saw the ammonia very highly elevated. We said it's a urea cycle, most likely early defect. And the abnormal lab here, you saw the ammonia, and we spoke about the active management of the disease. The last case is a mother lost 2 infants with metabolic disease, delivered baby 5 days ago, and then came to the emergency room with abnormal movement lethargy, opistotonic positioning, boxing, pedaling movement, looks like seizure, abnormal odor, and in the urine, and all labs are normal. Basic labs, CBC, electrolyte, glucose, blood gas. So here, this is a typical presentation of maple syrup urine disease. And here the urine will smell like maple urine, maple syrup, and اللي هو السكر المحروق. And this one needs really a high index of suspicion. Here you have to stop the all protein intake, give high dextrose, probably 20–25%. You may use insulin. Check plasma amino acid. Of course, you will involve the metabolic physician, and most likely dialysis may be required if leucine is more than 1,000. Especially if they are severe, they have severe CNS insult, then most likely they will require dialysis. They will require a CT brain. All these cases will require CT brain to assess cerebral edema or stroke, metabolic stroke. So the primary metabolic problem here is basically leucine encephalopathy. Leucine, you have to measure plasma amino acid, not readily available in all emergency room. And the suspected metabolic disease is MSUD, and the lab test plasma amino acid. Here we have to call the lab and expedite the test. And the treatment again is the same, high dextrose, but here in MSUD we tend to use 20%, 25% dextrose, even with insulin, to promote anabolism and stop catabolism. And often we have both the low threshold for dialysis. Once you do this, normally the leucine will come down and the patient will be better. All these diseases that we mentioned, MSUD, arginosuccinic, citrullinemia, urea cycle, propionic, they are amenable to liver transplant. So early diagnosis is critical, early management is critical. MMA is debatable, but some cases have been taken to liver transplant. We need to build more experience with them. But the majority of these conditions, they require will have significant improvement after liver transplantation. 2 points. If you are thinking about biotinidase, then biotin is the treatment of choice. And for suspected cases of tyrosinemia, there is a treatment with NTBC or nitisinone, which shows a dramatic also improvement. With this, now exactly I think 30 minutes. So thank you very much all for listening, and I will be more than happy to answer your questions or receive your comments. Thank you very much.
Thank you very much, Dr. Mohammed Al-Awain, for this interesting lecture. And I think I have 2 questions so far for you. If you are around, we can give you the questions. Dr. Awain, are you around?
Yes, yes. Did you hear me?
Yeah, I can hear you. Excellent. طيب, Dr. Awain, there is a question here. IV biotin can be given in emergency department for biotinase deficiency?
If it is available in the pharmacy, yes. It's a B complex actually vitamin. The dose we use is relatively high, but it is available like in iHerb and these nutritional stores. They use there, I think, 1 milligram. We tend to use 10 to 20. We diagnose cases with seizure disorder due to biotinidase deficiency. Of course, we have to do the biotinidase assay. It's part of the newborn screening, by the way. So if a patient comes to the emergency room and you are able to double check the newborn screening and you find biotinidase low, yes, go ahead. It's a very safe medication. It's like thiamine, riboflavin, extremely safe and very effective.
Okay, excellent. Thank you very much. Another question, which modality of dialysis is preferred in case of hyperammonemia?
Dialysis in general, by the way, for metabolic patients is used for severe hyperammonemia. We're talking about more than 300, 500. It's used for refractory acidosis. And it's also used for severe leucine encephalopathy, the one in the MSUD more than 1,000. Because of the technical issues, in neonates, peritoneal dialysis is more feasible. For the other ones, older patient, CRRT is better, but occasionally we use hemodialysis if there is a clotting problems, technical issues, but normally CRRT is the modality for the hemodialysis. And all of them require ICU setting and nephrology involvement.
Thank you very much, Dr. Mohammed, for this excellent presentation, and we'll wish to see you again, inshallah, for future courses and conferences. Thank you.
Thank you very much. Thank you. Have a good time.
Thank you. Our next speaker, it's my pleasure now to invite our next speaker, Dr. Al-Walid Abu Shannan. He's a consultant and chairman of pediatric dentistry at University, King Saud University, and also he's the chairman, Department of Preventive Dental Science at Prince Sultan bin Abdulaziz University. Dr. Al-Walid, you can start, please.
Hello, everyone. I'm extremely thrilled and excited to be joining you here with my colleagues in the emergency medicine and international conference. And we're going to be talking today about dental emergencies and how to handle them. It can be extremely stressful situation for a lot of physicians, especially if you don't know or encounter a lot of cases in the emergency department. So you get called, parents are anxious, child is crying, And in most instances, timely action is extremely crucial. So what is truly considered a dental emergencies? Sometimes it can be hard to tell if a dental problem is truly an emergency that needs immediate attention or if it can wait. These emergencies can range from dental trauma, facial swelling, dental pain, or just kids being kids sticking things in their mouths. And the decision can be especially stressful on weekends or after hours where access to dental care is difficult. So it's important to differentiate a true dental emergency from a simple deviation from normal. A lot of kids might experience dental pain just when they are going through a phase of dental teething. In other instances, they can just have an ulcer that is causing them excruciating pain. However, there's a range of dental emergencies that require immediate action, and some of these are considered to be either uncontrolled hemorrhage, facial swelling, dislodged or knocked out teeth, jaw injuries or fractured, and severe spontaneous pain. I'm sure that as emergency physicians, you encounter a lot of dental related visits, albeit whether it's during working hours or after hours. And in the United States and in Saudi Arabia, there has been a remarkable increase in dental related visits to the emergency department. The surprising thing is that most of these visits are atraumatic dental pain that account for the most emergent visits for patients. When it comes to traumatic dental injuries, nearly 25% of all school children experience dental trauma, and 33% of adults have experienced trauma to permanent dentition. So it's not uncommon to encounter such traumatic injuries as well in the dental department, in the emergency department. And in a lot of these traumatic injuries, timely management is crucial for the prognosis and survival of teeth. And the issue with traumatic injuries is that affects the teeth, which will be stressful for patients and their parents since it provides aesthetics, function, and the parents might be extremely anxious in how to manage it. Now, the dilemma lies on the child's medical status. Whether be it acute or chronic, it may greatly influence how, where, and when dental treatment can be provided safely. So for instance, loss of consciousness anytime following a trauma, embedded projectiles in the head and neck region, uncontrolled systemic disease, such as uncontrolled diabetes, patients that are immunocompromised, or children that are taking steroids, hemophilic patients, dehydrated patients, sickle cell anemia patients, or any hemodynamic instability, as well as erratic and potentially unusual behavior, which I encountered and experienced firsthand when I was on call, and I had to go in for a patient that was a teenager that was going through a manic episode, and that also provides extra stress in how to manage these emergency visits. Now, let's go through some of the most common dental-related visits to the emergency department, and I'm going to provide some briefing on how to maybe alleviate the stress, help you out in managing these emergent problems. So first thing is most of the visits will going to be regarding dental pain, and dental pain is mostly caused by cavities, which are caused by time, bacteria, and sugar all combining together and progressing until there is a cavitation in teeth. And this process is extremely long, so it takes years until, in most cases, it takes years until it could cause dental pain that have reached to the nerve of the tooth. Now, depending on the extent and location, the signs and symptoms of cavities can vary. As decay gets worse, children may notice sensitivity, spontaneous pain, sharp pain when eating or drinking, and whenever they're biting down, they will have issues as well. And whenever you open their mouths, you're going to notice that there are visible pits or holes in their teeth. And unfortunately, as emergency physicians, you will not be able to manage these cases in the emergency department, and you would have to refer to the local dentist or pediatric dentist to manage them. However, what you could provide is basically analgesics and palliative care. So your go-to would be ibuprofen, acetaminophen are the medications that we recommend. Sometimes, however, what you could do is you could help them rinse their mouths with warm water and gently floss to remove any debris or food particles that are stuck in these cavities. Or you could, if you have any certain small instruments that you could use, you could pick out some of these particles or food that are stuck in the cavities, and that will surely alleviate the pain. One other thing, especially if kids are cooperative and are able to help you out, you could provide them with intraoral local anesthesia that will also help reduce the pain and provide them with the pain relief. And this also raises the importance of having the resources that you could provide in the emergency department to parents and caregivers on how and where to seek dental care, especially when there's an issue of access to dental care. Because a lot of these patients will not be able to manage the problems that their children are going through. And that visit might help them out and provide them with resources, referral points, access to dental care as needed. Another issue that you might encounter is when kids or teenagers specifically are undergoing orthodontic therapy and having braces on, the wire that holds the braces in and moves the teeth might be poking at the back and causing ulcerations in the oral soft tissues. And that is because the wire could be longer than what's recommended. And the simple solution for that is to remove the cause of the ulceration, which is the long wire. And it's going to be difficult for you to remove the wire wholly. So what you need to do is just maybe retract the cheeks a little bit and then cut that long end and clip it out. You can use whatever instrument that you have to cut any stainless steel or nickel wires in the emergency department. Now, one of the most common emergency visits to the department could be facial cellulitis or facial swellings that are caused by odontogenic infections, which is mainly caused by cavities as well. And obviously, the most important thing is to manage it accordingly. And the problem with facial cellulitis in kids is that a lot of kids would require admission to the hospital for IV antibiotics, depending on the severity of the facial swelling, if it's extending to the eyes or causing any respiratory or airway issues for the child. So in these cases, what you need to do is mainly control the abscess or the swelling by administering antibiotics. and that will hopefully reduce the swelling. And following that, what you need to do is just refer the patient and the parents to the pediatric dentist to manage the abscess tooth, which would most likely be extracting the tooth if it's a baby tooth, or providing root canal therapy if it's a permanent adult tooth. Now, the funny thing is it always a dental infection that causes facial swelling. In other instances, like our little friend here, it's not a swelling that's caused by an infection. This little guy was planned to have a dental treatment under nitrous oxide in the dental clinic. However, after local anesthesia, his cooperation level started to deteriorate and the treatment was aborted. The mother was extremely anxious and she called after nearly 3 hours, saying that the child is still numb, his cheeks are swollen, and had a fever. So what we did was we instructed her to give acetaminophen and monitor the fever. Eventually subsided. And later on, what we found out is that because of the numbing and because of the administered local anesthesia, the kid chewed the inside of his cheeks. So be mindful that it is a common occurrence, especially in younger children, that due to the unusual numbing sensation, they start to bite their cheeks or lips. And most of the times there is no intervention required in these cases, and it's just allowing the soft tissues to heal. So uncontrolled hemorrhage, you might encounter these cases, especially for kids that have gone under treatment, dental treatment under general anesthesia, or had a treatment at the day of the visit. And a lot of these kids that undergo treatment under general anesthesia will require silver caps or caps in general on their baby teeth, or have multiple extractions. And that would cause some continuous bleeding that would not stop the whole day or for 2 or 3 days. In most cases, history for bleeding disorders must be confirmed, as well as running a panel to test for clotting disorders. However, as I mentioned, following treatment, the soft tissues, the gums of the teeth will be injured, and liver clots will start to develop. So your goal is to remove the clot, rinse, and use your local measures to control the bleeding, applying pressure, and so on. If there were multiple extraction sites, you could help the patient by suturing the gums if needed. Now, another trick that you could use is you could use your tranexamic acid, have gauze that's dipped in tranexamic acid, and have the child bite on it for a few minutes, and that will generally help control the bleeding and stop it. I've used this trick on numerous occasions, and it always works wonders. Another pro tip is to use black tea bags. So black tea bags, they contain high levels of tannins, which has vasoconstrictive and coagulation properties. However, ensure it's damped and cooled, and apply gentle pressure on the desired area, and that will also control the bleeding. So if you're not going to use it in the emergency department, what you could do is after you control the bleeding of a child, you could instruct the parents, if bleeding continues at home, that's what they could do to manage it. So another common cause for dental emergencies would be trauma. So orofacial dental traumas is common in school children, children that are playing sports or contact sports. motor vehicle accidents as well. So the first few things that we should always inquire about is what was the patient doing that led to the trauma, or what happened? How did the trauma occur? How long was the trauma? And you have to ask specifically in minutes, hours, and days, because sometimes it's crucial, especially in avulsion or knocked out teeth, how long the tooth was out of the oral cavity. Where did the injury occur? Was it clean or dirty? And was there anyone that witnessed the trauma? Was it a witnessed traumatic injury or not? And you could also rule out abuse. You don't want it to be a fight or someone that caused the trauma to the child. And that will lead us to a whole issue of medical legal factors. So first thing first, it's extremely important to differentiate between the management of baby teeth versus permanent teeth. And a lot of trauma injuries in baby teeth, you would not have to do anything unless the baby tooth is causing occlusion problems, so the child cannot bite properly, or the tooth is extremely mobile that it's an aspiration risk. So in these cases, what you need to do is just pull the tooth out and alleviate the pain. If the tooth has been dislodged and not in its place, what you could also do is try to kind of push it back in place, or at least alleviate that occlusion problem so that the child can bite properly, and just recommend them to be on a soft diet and avoid any contact sport for the next 2 weeks, and obviously just refer them to the dentist. Now, if you encounter such injuries to the soft tissue where there's a degloving injury of the soft tissue or the gums, if time permits and the behavior of the child permits, what you could do is you could suture the gums back, and that would hopefully control the bleeding and the pain that the child is going through. However, the soft tissues, the oral soft tissues are extremely quick in healing. So a lot of these cases where we encounter young children that have undergone or have been through dental trauma, and we are not able to manage by suturing the gums. The gums heal pretty quickly and naturally without any intervention. So just keeping the area clean, asking the parents to rinse thoroughly every day, and avoiding any hard foods. And just similar to this case, we were not able to suture the gums back. And 1 week later, the child came back, and the gums have healed pretty well, and you can see everything is tidied up. So in a lot of these injuries in children, you don't necessarily have to do something, and just reassure the parents that it will heal naturally. And now this is what I mentioned previously about if you had a dislodged tooth. And so if you look at the upper central incisor here, it's a baby tooth and it's been dislodged from its place. Now the child, if the child bites down, he won't be able to bite naturally and comfortably, and it's going to be causing a lot of pain because the tooth would be moving back and forth. And so what you need to do is try to gently press behind the tooth and push it back in place if possible, and the tooth will be stabilized at the time. However, if the tooth is extremely mobile, causing aspiration risk, just attempt to pull it out if possible, and just make sure that it's a baby tooth, not an adult tooth or a permanent tooth. So what I'm going to be talking now about is mostly the management of traumatic injuries in the permanent or adult teeth, which requires crucial action at the time of visit. So the most common traumatic dental injuries are uncomplicated crown fractures. So basically the crown of the tooth would be chipped and the nerve of the tooth has not been exposed. So these are extremely easy to handle and manage, and only observation and follow-up with the outpatient dentist for consideration of rebonding that chipped fragment is required. And from your end as emergency physicians, there's nothing that requires any immediate attention. However, in complicated crown fractures, which is on the right-hand side here, the exposed pulp would cause a lot of pain and sensitivity. And what you need to do is you can provide them with some sort of a bandage using calcium hydroxide if you have any in the emergency department, and apply it on the exposed pulp. The exposed pulp would appear as a clearly pink tissue within the tooth. And just arrange for the patient or the child to visit the pediatric dentist for management later on. So this is a case that I managed previously, and you can see that the tooth was chipped in the central portion of the crown, and the pulp is exposed. You can see it as the pink tissue here in the middle, and that's extremely painful for children because if they breathe, if they drink water, if they eat, it's gonna be extremely painful for them. And so what we did was basically provided them with calcium hydroxide applied over the exposed pulp here, and then we attached the fragment and good as new. This is another case as well. The child came in with the tooth fragment, and you can clearly see the exposed pulp here. And so the management would be similar to what I described in the previous case. And so it's important that you guys have calcium hydroxide available in your emergency departments. If you do not have access to dental care or dental department in your hospital. So it comes in a syringe, and you can just apply it gently. You have to dry the tooth out a little bit with a gauze, and then just apply it over the exposed pulp, and it should set quickly. And then just maybe wrap it in gauze and send them off to the dentist to manage the rest of the trauma. Other traumatic injuries are luxation injuries. So luxation basically is a dislodged tooth. So the tooth moved from its place either backwards, forwards. It could be an extrusion where the tooth would look or appear longer than normal, or it could be an intrusion where the tooth would be shorter than normal and it's just pushed apically towards the bone. Similar to this case here, where you can clearly see that there's lacerations, there's a lateral luxation of the central incisor, and lots of bleeding going on. The patient is extremely anxious and in pain. And so what we normally do is we try to push the tooth back in place and splint with a flexible wire and bond the wire to the teeth. Generally, whenever we use splints, you want to extend the splint towards two or at least one sound tooth adjacent to the traumatized tooth. In another case here, you can clearly see that the lower lip was severely lacerated. The gums are degloved as well, and the lower incisors have been luxated as well. So again, management would be to splint the lower incisors and suture the lip and the gums if needed. And that's what we do. So we used a 3/0 Vicryl suture. and just instruct the patient to avoid any hard foods. So continue on a soft diet, analgesics as needed, and follow up with a dentist for management and monitoring the traumatized teeth as well. Now, the most trauma injury that requires immediate attention is knocked out teeth or avulsions. And it's extremely crucial to manage these cases as soon as they come to the emergency department. Ideally, we want the parents to manage it, or whoever is responsible at the scene of trauma, to manage avulsed teeth and place them back in place right away, because the prognosis and the success of treatment relies on how long the tooth was left extraorally, and or if it was left extraorally, what storage medium was it left in. So obviously you wanna confirm the medical history, if the patient is immunocompromised or not, and the vaccination status. And that's because you want to confirm if the trauma or the knocked out tooth occurred in a clean area or a dirty area. Was it in the park, outside, or was it in the living room? Obviously want to confirm the length of extraoral time, as I mentioned, and the storage medium that the tooth was carried in. And symptoms, so pain, mobility, any change in occlusion, the bite of the child, did it change or not? And that's what generally occurs, is the tooth would be out of the mouth, the socket would be empty, and you want to basically pull the tooth back from the crown of the tooth and push it back in the socket in place. So again, time is extremely key to prognosis. It's crucial to manage it as soon as possible. And obviously, as I mentioned earlier, primary teeth should not be replanted back in, because that would cause trauma to the developing permanent tooth inside. So we only replant adult permanent teeth. So you need to confirm that with age, and you confirm it with the parents as well. So how do you handle it? So again, you hold the tooth from the crown, you clean the root surface with a stream of saline, soak the tooth in saline to remove any debris, irrigate the socket with saline as well. Use local anesthesia because it's going to be painful for the child. You replant the tooth with gentle pressure, and then if possible, you use a flexible splint to hold the tooth in place, and just refer them to the dentist to follow up and manage accordingly. So some of the keys to successful trauma management is to identify on-call pediatric dentist or maxillofacial surgeon. It's extremely important for us as clinicians to develop a habit of working together as a team for the benefit of our patients. And so identifying on-call pediatric dentists, maxillofacial surgeons is crucial for the management of emergency visits on a day-to-day basis. You need to ask for a head and neck imaging, especially if there are missing teeth or probably chest or abdominal films to rule out any aspiration or ingestion of the teeth. So that begs the importance of counting all the teeth whenever you see a trauma case. You have to count all teeth and make sure that they are visible. And avulsed teeth, urgency is extremely important for the prognosis of the tooth. If the tooth is extremely loose or a possible aspiration risk, remove, submerge it in a balanced salt solution if you cannot splint the tooth back in, and that's only for cases of permanent teeth avulsions. Make sure to conduct a good exam, temporize what is emergent, and then refer the patient to a pediatric dentist or a maxillofacial surgeon for follow-up and management. So some of the resources that you guys could use in the emergency department is you could log into the International Association of Dental Traumatology. They have an excellent guideline with pictures, diagrams on how to manage every trauma, every dental trauma possible, and that will help you in managing your cases with ease. And remember, it's extremely stressful, especially if you're not prepared. So try to orient yourself and your team with dental trauma and dental emergencies, and that will hopefully make it a pleasant experience for both you and your team, the parents and the child as well. I'll be more than happy to answer any questions. Here's my social media accounts and my email, and thank you for having me.
Thank you very much, Dr. Walid, for this very interesting overview of trauma and injuries in children. And we used to see a lot of cases coming to the emergency with this kind of traumas. We have I think there is only 2 questions, but I will give it to you. What is the best age at which dental implant can be applied if needed for a child?
Yes, hello, Dr. Mohammed. In regards to dental implants, generally speaking, you'd have to exceed the age of 18 years in order for the dentist to be able to place an implant. There are few case reports of implants being placed on younger children, but it's not extremely successful.
I see. Okay, the next question, what are the differences between dental and dentigerous cyst?
So it's not very clear, but I think what he's saying, if it's a dental infection and if it's a dentigerous cyst. So dentigerous cyst, it's an odontogenic cyst that develops around unerupted teeth or impacted teeth. So teeth that are still developing but get stuck and are unable to come in the oral cavity. And the management would be more surgical rather than in cases of dental infection, where you would probably drain and remove the cause of the infection. So either by performing a root canal treatment or extracting the affected tooth.
The next question is, what about tongue bleeding after a trauma? Who can treat this patient, maxillofacial or dental? Dental doctor. And what is the role of emergency physician consultant in this case? You can start, Dr. Al-Walid.
Yes, and in regards to a tongue laceration, so either a pediatric dentist or an oral maxillofacial surgeon, whoever is on call, will be able to handle these lacerations. So basically just suture it if possible. Emergency physicians are equipped and capable as well to suture the tongue. If the child is unable to cooperate in the emergency department, so what you can do is just maybe provide them with sedation and suture it. But in most cases, tongue lacerations, if you are unable to suture at the time of the visit, you can just leave it as is, and it's gonna heal up just well. However, depending on the severity of the laceration, if it's a through and through laceration or not.
Okay, thank you very much. For the role of pediatric emergency consultant in case of bleeding, usually, if the laceration on the periphery, usually we don't, usually this is the case where you should suture. If it is in the center through and through, and it's not that big, large that make a flap, you leave it. Within 24 hours, it will heal dramatically because of the high vas. At the end, I would like to thank you all for your attendance. And if there is any question or anything about the conference or future activities, my account is Alfaifi @Alfaifi911. You can reach me. I think most of you know me. And inshallah, we will continue doing these courses in the, I mean, every 2 years, even every year. And for any question, we are more than happy to answer, and wish you the best of luck. And thank you very much. And don't forget, please, before that, to finish the questionnaire. Okay, you can fill the questionnaire so we can submit your certificate for all of those who attend. Thank you.